और सभी को लेके कोई बच्चा सर सेकेंड थर्ड डाल
And for judging the oral paper presentation, we have Dr. O.P. Mishra sir. Sir needs no introduction from the IMS BHU sir, welcome sir. Dr. Diwan Amar sir, IGMS. Sir, is the professor of pediatrics, IGMS. I welcome you sir. पाँच लोग डॉक्टर विजय शंकर सर, डॉक्टर मजीबुल्ला अंसारी सर एंड डॉक्टर हिमेश बर्मन सर. I will request the first speaker, Dr. Sagar, to please come on the dais. The time allotted is only 5 minutes. You have to finish in the 5 minutes. The screen will go blank after 5 minutes. So make sure to finish on time. For the poster presentation, we have judged Dr. Rajiv Sinha sir, Dr. Prem Shankar Patel, Dr. Anil Jaswal, and Dr. Satyam Mohan. I will request Dr. Saurabh Suman to please coordinate for the poster presentation. If the sir will permit, Dr. P. Mishra sir will start with the oral paper presentation. Sir, I will invite the first speaker, Dr. Sagar.
सब बिजी है ना. क्या बोलता है ऊपर?
Good afternoon, we will present a case on comparison cost formula creatinine clearance. The assessment of GFR in children aged between 5 to 12 years with kidney disease. Introduction: acute assessment of kidney function syndrome is a cornerstone of pediatric nephrology. Early recognition of declining GFR allows timely intervention, better outcomes, and prevent complications of chronic kidney disease. Additional major methods such as injury clearance are not feasible outside research setting. Creatinine clearance, though widely used, is limited by the need of meticulous 24-hour urine collection, which is particularly challenging in children. SWOT's formula, which uses height and serum creatinine, provides a simple bedside tool to estimate GFR. The significance of GFR, kidney filtering capacity is the best measured by GFR. Tracking GFR is critical because a falling GFR is a key sign of worsening CKD. It is used to measure, to determine the stage of CKD. Accurate GFR is essential for correct drug dosing and predicting long-term outcomes. The practical challenges are the ideal method that is insulin clearance in the complex, not feasible for everyday clinical use. The common method, creatinine clearance, requires a full 24-hour urine collection. This is obviously difficult for children, cumbersome, often leads to significant development of collection errors, is inconvenient for families and staff. This creates a need for a simpler reliable method that is Swartz formula. It's given, the Swartz formula is given by estimated GFR is equal to K into height in centimeter divided by serum creatinine in milligram per deciliter, where K is constant based on the child's age and gender. The benefits are easy to calculate at the bedside, only requires a single blood sample and height measurement, avoids the problem of 24-hour urine collection. Aims of the study was to assess the validity of Swartz formula as compared to the measurement of creatinine, plus the cost, effective and time-saving method for estimating GFR in children with kidney disease. The primary objective was to test the accuracy of Swartz formula against the standard 24-hour creatinine clearance. Calculate the GFR using Swartz formula, measure the GFR to a careful 24-hour urine collection for creatinine clearance. Second subject was to validate the correlation and diagnostic accuracy. The materials, the study was done in Assam Medical College Hospital. The type of design was hospital-based cross-sectional study. Was done for 1 year. The study population included were the children between the age of 5 to 12 years with nephrotic syndrome, acute glomerulonephritis and CKD. Exclusion criteria were obstructive uropathy, SAM, analyzing the results, supervised 24-hour urine collection for measuring creatinine clearance, draw blood sample for serum creatinine, calculate GFR using Swartz formula. The statistics used are the PSN correlation, bland Altman plots, and calculate sensitivity and specificity to test the diagnostic performance. The gender distribution of the study participants were about 50. Male was 34, which accounts for 68%, and female was 16%, accounts for 32%. And this table showed the baseline characteristics of the study. Participants, the children aged between 5 to 12 years, including anthropometric, biochemical, and renal function parameters. And this table in image shows the GFR by Swartz formula. In study participants, most of number of children, that is 60% in the study group, had a GFR value of 75 ml per minute, 1.75 meter, suggesting a reduced renal function, and remaining 34% children had a GFR in the normal range. And this table and image shows the GFR by creatinine clearance. According to this formula, majority of the children, that is 62%, had a GFR of less than 75 ml, and remaining children, that is 38%, had a GFR of more than 75 ml. This validates the Swartz to the reliable indicator for renal function estimation. Discussion. The static analysis revealed a very strong positive correlation. The correlation of coefficient was 0.815, was highly significant. This indicates that measured GFR is increased or decreased. The Swartz estimate followed very closely. We tested its ability to identify children with clearly reduced kidney function, that is GFR less than 75 ml. Sensitivity was about 93.6%, specificity was about 78.9%, with the overall accuracy of 86.3%. The bland Altman plot showed that the average difference between two methods was small. While there was some variation, the agreement was found to be clinically acceptable for use in most routine clinical situations. Our study shows that Swartz formula is a reliable tool for estimating GFR in Indian children with kidney disease. Its strong correlation with the high sensitivity make it excellent alternative. This is particularly available in busy clinics with a limited source and cost-effective method, and it's quick. Limitations of the study were inter-individual variation, over and understood the extreme renal function, single-center design of limitation. Conclusion: Swartz formula is a valid practical tool for estimating GFR in children 5 to 12 years with kidney disease. It effectively replaces the 24-hour creatinine clearance, and we recommend its adoption in clinical practice. Implication in practice are to reduce the burden of 24-hour creatinine collection, screening and monitoring pediatric kidney disease, useful in pediatric intensive care units, and larger studies across multiple centers in India to strengthen these findings. Thank you.
Okay, thank you, Dr. Sagar. How did you calculate the sample size of 50 that should be enough for this study?
So, based on the study done previously in Lady Edwin's College in Sri Lanka, sir, we took 9.8%, sir, with a confidence interval of 95, sir. With 90% power, sir, we reduced the sample came 50, sir.
That was not so. And second, your area under the curve was 86.86.
0.86.
So, is it strong? Very high?
Sir, compared to previous studies, sir, it's not that much high, sir, because of there are difference in the sample collection. See, our studies are less sample base, and there are clinical correlation is different, sir.
Which formula did you use? Scott's formula?
Sir, particularly, sir, that height into K into height in centimeter divided by serum creatinine, sir, in the
What is the K value here?
K value, sir, usually we take, sir, in preterm we take,
In your
in our, sir, we take as 0.45 to
0.4?
0.5, sir.
0.5 or 0.413. Now, which K value you have taken in your study?
So in this, sir, we took as 0.52, sir, 2 to 12 years.
What is the novelty of this study had already done? What is the novelty of this study?
Sir, for this
Any
study,
new things which study added to the
sir, this is a small population-based study, sir. It requires, since it's a small population-based study, sir, it requires a multi-center study, sir, again to correlate creatinine clearance with SWOT formula, sir.
Sir is asking what is the new in your study? Anything different from the other study? What is the exactly same which was done earlier? Any other?
Sir, initial earlier study, sir, we got, sir, coefficient of relation a little bit less, sir, because of small sample size and different in the disease, sir. We analyzed only, sir, nephrotic syndrome and acute global nephritis, sir. And so we can't extrapolate the results to the other kidney diseases, sir.
Very good presentation. What are your inclusion criteria?
Sir, we included, sir, age group of, sir, 2 to 12 years of age group, sir.
And about the disease?
Sir, in our setting, sir, we included, sir, in this sample, nephrotic syndrome, acute global nephritis, we included, sir.
And what about API?
We excluded, sir.
Why? What is the reason behind including the API? Okay, thank you.
Thank you, sir.
Thank you, sir. I will request the next speaker, Dr. Ria, and I will request all the participants presenting the poster to come nearby their poster. If they are coming by, all the participants who are presenting the poster, come to their poster. And Dr. Ria.
Good afternoon, everyone. I will be presenting a comparison of 1-year renal outcome of cyclophosphamide versus mycophenolate mofetil, an interim report from the prospective Indian Childhood Lupus Nephritis Registry. So, as we know, MMF and cyclophosphamide are both accepted as first-line induction agent in lupus nephritis, but there is scarcity of comparative data regarding their effectiveness in achieving renal remission in pediatric population. We are hereby presenting an interim data on the renal remission rates achieved with these two agents in our study. So this is our ongoing prospective multi-centric registry endorsed by the Indian Society of Pediatric Nephrology involving 9 centers across India and was initiated in August 2020. Children aged less than 18 years diagnosed with SLE as per SLIC 2019 criteria and confirmed with lupus nephritis by kidney biopsies were enrolled. And children with drug-induced lupus, mixed connective tissue disorder, or with parents not willing to give consent were excluded. At enrollment, basic demographic information, clinical parameters, lab parameters, and histological characteristics were noted. Treating physicians are at liberty to choose treatment regime in line with the standard protocol. Patients are followed up at pre-specified intervals. Renal response was assessed in terms of 4 renal parameters, that is proteinuria, urine RBCs, WBCs, scars, and serum creatinine at defined time points and categorized as complete response and partial response or no response. Any adverse events like end-stage renal disease, death or switch in therapy was recorded. We are hereby presenting a comparison of 1-year renal outcome data of children with proliferative lupus nephritis who have received cyclophosphamide as the induction agent versus those who received MMF as the induction agent. So the total number of patients enrolled till now from August 2020 is 125 patients. The indication for giving additional induction agent were inability to achieve renal remission and extrarenal manifestations despite pulse with hydroprednisolone. So we have complete 6-month data of 113 patients out of 125 patients, among which we found that proliferative lupus nephritis was seen in 88 patients. Cyclophosphamide was given to 25, while 63 received MMF. At 1 year, we have complete data of 87 patients, proliferative being 66, 23 received cyclophosphamide, while 43 received MMF. So the baseline parameters were compared, that is age, gender, EGFR, proteinuria, AKI, and histopathological findings among both the groups. But no significant statistical difference was found, except that we found that cyclophosphamide given more in males. So at 6 months, the comparison showed that the need for second-line therapy was higher in cyclophosphamide group. Complete remission initially was higher in cyclophosphamide group, and total remission, that is CR plus PR, complete remission and partial remission, was same in both the groups. While comparing the data at 1 year, we found that the need for second-line therapy was still higher in cyclophosphamide group, while complete remission was higher in the MMF group, and total remission was slightly higher in the MMF group. So the result we have so far indicates that MMF is as effective as cyclophosphamide to achieve complete remission at 1 year in children with proliferative lupus nephritis. Although the difference is not statistically significant, the numerical trend strongly suggests comparable efficacy. The finding is clinically relevant because cyclophosphamide carries significant side effects, particularly gonadal toxicity, especially concerning patients of pubertal group, and SLE presents mostly in this age group. While our current data set supports the potential of MMF as a safer yet equally effective option, being a prospective study, further data collection and analysis are ongoing, and we plan to present a more comprehensive report soon. These are all the 9 centers included in this study. Thank you.
Okay, thank you, Dr. Ria, for this comparative study presentation. What was the MMF dose did you use in this study?
Sir, the dose, starting dose was around 300 milligram per meter square per dose twice daily, and it was given maximum up to 2 to 3 grams per day.
Okay, and the number of doses of cyclophosphamide per emission reduction?
Sir, actually, according to the protocol, it's 6 doses, but different studies, different centers are giving their treatment, so exactly how many doses at all center at what patient, the data we are still collecting. So,
but do you think that it will matter 3 versus 5, 3 versus 6,
Yes.
3 versus 4? So that was not homogeneous.
not right now, sir. We are still doing this. So,
Okay.
You have concluded that MMF and cyclophosphamide are equally effective. That's your conclusion.
as equally effective, yes, sir.
So, but if you look at your loss to follow-up in terms of not having data at 1 year, you have lost proportionately much larger number of patients on MMF compared to cyclophosphamide. So it is possible that you have lost to follow-up those children who did not respond, and could that have introduced a positive bias in favor of mycophenolate?
So first thing, actually the patients are not lost to follow-up yet, but
in
yes,
terms
yes.
of not having complete
Yes,
data, that
yes.
means you have excluded that. So that means that it's possible
Yes,
that those
sir.
children who did not achieve remission were not included in the study,
Yes, sir,
thereby
possible.
increasing the prospect of mycophenolate.
Sir, yes, sir, possible.
Question is, and the same question, in follow-up, not completed the MMF, then how you assess the data? You have tried intention to treat or not during analysis?
Sir, till now, no treatment, the centers are deciding as per the standard protocol, the guidelines we have already. But this is just an observation till now, what we have seen, that MMF is acting equally effective till now. So,
During analysis, you have analyzed the field.
yes, sir.
You have analyzed who have not completed the treatment course. You have included in your analysis.
No, sir. These are who have completed till 1 year complete data we have. Then we have taken that patient in our study.
And those
Till
not
now,
completed and those not completed.
still we are collecting data, sir. So,
Yeah, one of the last questions. As you said that the cyclophosphamide receiving of male is more.
yes,
Why?
sir.
Any idea why the male children have received more
Sir, we know from the theory that males are more severely affected, but in this study we did not find any difference in AKI, proteinuria or EGFR till now. So,
But like any comparison, like you have just written proliferative DNA. So which stages of proliferation, like 3 or 4, like we have not distinguished between.
sir, we have taken 3, 4 and 3 plus 5, 4 plus 5 also.
Yeah, but not given the exact data which grade 3
In which-
cyclophosphamide and grade 3 plus 4 or 5 in these groups. That
We
is
are collecting that data also. Because of the less time, sir, I did not include in this
Okay.
presentation.
Last question. You didn't mention about the adverse effect profile between these two.
Sir, till now we don't have that data.
Okay.
That is the reason.
Okay, thank you.
Thank you.
Thank you, Dr. Ria. Next we have Dr. Pallavi. Dr. Pallavi, please.
Good afternoon, everyone. Today my topic is role of continuous renal replacement therapy in critically ill children in a tertiary care hospital. The objective is to narrate clinical profile and outcome of children who underwent CKRT in PICU of tertiary care hospital in eastern India. It was a retrospective analysis that was done from July 2021 to August 2025 in critically ill children in PICU requiring CRT due to renal and non-renal indications. Total 34 patients were part of the study with equal gender preponderance. The median age was 8.5 years, the youngest being a 1.5-month-old baby and the oldest was 18 years of age. The median weight was 30 kg, while the smallest was 2.9 kg and the largest was 99 kg. This is a diagram that depicts the diagnosis and the indications as to why CRT was initiated. The right side depicts the diagnosis or the etiology. 24% of patients were diagnosed with dengue, 18% had septic shock, 8.9% had nephrotic syndrome, 18% had adenoviral mods, and 6% had MAS. The most common indication as to why CRT was initiated was fluid overload that forms 32.3%. Time to initiate CRT since admission was 23.5 hours and the interquartile range was 8.75 hours to 55.6 hours. The most common machine that was used was Prismaplex that formed 67.7%. The Prismax was used in 32.3%. CVVF HDF was the most common mode used. Median doses for AKI and no hyperammonemia was 35 ml per kg per hour and with hyperammonemia was 40 ml per kg per hour. The median CKRT duration was 27 hours with an interquartile range of 15.37 to 97 hours. Now, depending upon the different weight bands, we have different types of filters, HF20, M60, M100 and Oxidus. Cytosol is used in different patients if they have cytokine storm. So one was used in HF20, one was used in M60 and 4 was used in M100. The most common axis that was used was right femoral that was in 15 patients that formed 44%. 9 patients heparin was used and 22 patients because of DIC, NS flushes was used. 56% of patients the filter clotted and 59% of patients NS flushes was used in which filter clotted. The patients where heparin was being used as the filter clotted, if they were shifted to RCA in which we did not encounter any filter clotting. The significance that was noted in heparin and NS flushes was P-1.0, whereas the significance that was noted in RCA, heparin and NS flushes was P-0.2. The dynamic outcome parameters was noted with respect to 2 parameters, that was oxygen index or the mean airway pressure and fluid overload percentage. So it was noted that the oxygen index that was seen at initiation of CKRT with respect to the oxygen index on discontinuation drastically improved, and the same was noted with respect to fluid overload percentage. The median fluid overload percentage, the range was between 4.8 to 32.2%. On CKRT discontinuation, it was seen that 9 patients expired, 15 patients, they still required other forms of kidney replacement therapy. AKI without kidney replacement therapy was used in 9 patients, and 1 patient, the AKI resolved. The survival rate that was noted through the timeline was 45%, where around 6 patients survived, whose diagnosis was due to hyperammonemia. 2 patients survived of cytokine storm, around 5 patients survived of fluid overload, no patient survived of toxin removal, and around 3 patients survived due to metabolic acidosis. Conclusion: CRT, though an expensive but can be a life-saving modality, not much analysis has been done regarding whether early initiation of CRT can reduce mortality rates in sick children, and the most significant complication that was noted during this retrospective analysis was the clotting of the filter. Thank you.
Okay, thank you, Dr. Talur. Did you analyze your 9 mortality data in relation to etiology of the disease?
Yes, sir. The etiology of the patient had played an upper role and not the CKRT.
No. Those 9 deaths were in which group? Dengue or some other disease?
So mainly it was due to dengue that we had noticed, and secondly it was due to cytokine storm, and 1 patient that expired was due to paraquat poisoning. So it was mainly due to the etiology of the patient.
9 deaths, how many belong to the diagnosis of dengue?
So 3.
And the rest 6?
So 2 patients was of SLE mass, 1 was due to toxin poisoning, and 1 was due to acute liver failure due to hyperammonemia. So it was like a small baby who died.
Setting up the CRRT did affect the outcome?
Yes, sir.
In which group you have had high mortality here in your study?
So adenoviral or the cytokine storm.
Which group you have faced a problem in placing the lines? And what was the in children? Your lowest age group was 2.5, I think.
Yes, sir, 2.5 kg.
So, what was the number of the catheter you used?
So it was 8 French.
Is it available?
Yes, sir. In ICH it is available.
8 French was easy to put in.
It was difficult, sir, but it was available and we had used it.
Clotting has done in your general patients. What we have done here is identifying patients.
So sorry, sir.
As you have presented that I think 40% patient having clotting problem.
Yes.
Then if clotting happens, then what you have done? You have stopped the CRRT or?
Sir, it depends upon the patient financial outcome. Some of the patients, there were 2 patients who were not ready to go forward with the treatment because of financial constraints. So we stopped the treatment, taking the consent from the patient party. With respect to other 3 patients, we had shifted them to RCA and then they worked well. Thank you, sir.
Dr. Matthew.
इशिता मैत्री अच्छा वो ठीक है उसके बाद
Good afternoon everyone, I am Dr. Ishita Maiti, today presenting a case series of pediatric ADPKD, a subgroup analysis of the multi-center cross-sectional cystic kidney disease project from India. So cystic kidney diseases are a heterogeneous group of contributing to the chronic kidney disease burden in the population. It as per North American trials and collaborative studies registry 2011, autosomal dominant polycystic kidney diseases is increasingly being recognized in children. We hereby present a descriptive analysis of ADPKD children from our multi-centric cystic kidney disease project. My study was a multi-centric cross-sectional observation study done in ICH Kolkata in a span of 2 years. Samples were collected as per convenience sampling with a sample size of 100. We included children less than 18 years of age with 2 or more kidney cysts in ultrasound scan. one kidney cyst measuring more than 1 centimeter with a positive family history cystic kidney disorder, typical presentations of polycystic kidney diseases, and prenatally detected hyperechogenic kidneys with renal cyst with oligohydramnios, and one kidney cyst measuring more than 1 centimeter with proven genetic mutations. We excluded cystic tumoral processes and multicystic dysplastic kidneys. We collected 111 cases, out of which 80 were genetically proven, and among them 25 had ADPKD mutations. Among them, which included 20 of ADPKD 1 gene mutations and 2 of ADPKD type 2 and 3 genes of both ADPKD 1 and 2 mutations. 4 out of 25 cases, that is around 16%, had de novo mutations. PKD1 and PKD2 variants were present in 31 patients, where 19 was of likely pathogenic variant, 6 reclassified, and 6 was variant of uncertain significance. Median age was noted around 7 years, youngest being of 3 months and eldest 18 years. 19 patients, that is around 76%, presented in a pre-adolescent age group. Female to male was 14:11 with no genetic preponderance. 68% of the patients, that is 17 out of 25 patients, were asymptomatic on presentation. 28% presented with hypertension, which included 6 only with hypertension and 1 patient with associated CKD. 1 patient had only 1 antenatal USG showing raised echogenicity and bilaterally enlarged kidney, but overall antenatal USG showing raised echogenicity and bilateral enlarged kidney, 2 children showed that. 5 out of 25 children, that is 20%, showed extra-renal manifestations. 1 patient showed raised echogenicity of the liver, 1 patient showed hepatomegaly, 1 patient showed intracranial aneurysms, 1 patient showed ASD defect, 1 patient came with ovarian cyst and GRD. On genotyping, 29 variants of PKD1 and 5 variants of PKD2, where most common variant was missense variant. 18 patients showed heterozygous mutations and 7 patients showed compound heterozygous. Among 18 patients, 3 patients had PKD2 mutations and rest 15 had heterozygous mutations. And among compound heterozygous, all of them belong to PKD1 gene mutation. Matching between the clinical predictions and actual genetic diagnosis of underlying cystic kidney disease. And wrongly predicted in rest 35%. We had genetically confirmed APNEICON-2025 cases. Among them, rightly clinically we diagnosed in 17 cases. So that means APNEICON were missed in 32% cases. We can conclude that APNEICON is the commonest of the inherited cystic kidney diseases. Even
LHCY positive, but you subjected all 75% for ultrasound. You subjected asymptomatic, all asymptomatic study subjects to ultrasound. Why? Out of 175 cases were completely asymptomatic. But still you subjected for ultrasound.
We did ultrasonography for other reasons. Some the patient came with the pain abdomen or loose motion. Some other reasons they came, not with the complaint of ADPKD features. So we did routinely USG for other reasons. But we accidentally found them as ADPKD.
Did you compare this data to European cohort APNEICON-2025 European Renal Kidney Disease Network? What is the pattern with us and their in relation to variant detected? These variants are different from the other four in review of literature?
No, sir. It matches with it.
Did you compare with any study?
Yes, sir.
Which study?
Sir, from the PubMed.
You should quote the reference number.
What is the criteria of diagnosis ADPKD in your population, clinically?
Clinically, sir, we do either USG or whole exome sequencing. In the USG, you have to find at least 2 cysts in both the kidneys, or if one cyst is present with some genetic family history positivity, or with some family history positivity, and if one cyst patient, one cyst is there with some other external manifestations, and a whole exome is positive for it when we consider it included in the output.
Any cutoff size for cyst size? Cyst size?
1 centimeter.
Thank you, Dr. Maki. Next we have Aditi. Dr. Aditi, please.
Good afternoon, everyone. Myself, Dr. Aditi. I am presenting a study on integrated genetic testing in the kidney disease, a single-center retrospective study from Eastern India that was done under guidance of Dr. Swanimam and Dr. Meerum. The clinical challenges with the monogenic kidney disorders are substantial proportion of the pediatric patient present with chronic kidney disease, and the conventional diagnostic tool often fails to precisely specify the etiology and therefore delay the appropriate care. And the most common condition associated are the SRNS, the nephronophthisis, the calcinosis, and the cystic kidney disease and HUS. Particularly, there is limited data that exists on the genetic testing outcome, specifically in the Eastern India, and that represent a significant knowledge gap. So this study highlights the shift of the traditional phenotype-based testing to the precise medicine by providing the regional data on the genetics. So the primary objective was the diagnostic field of genetic testing in patients suspected of hereditary kidney disease, and the secondary objective was to describe the clinical spectrum of genetic diagnosis and what are the most implicated genes and inheritance patterns in this cohort. So it is a single-center retrospective observational cohort study that was done in Department of Pediatrics in AIIMS Patna from July 2023 to July 2025 for 2 years. And our population was a retrospective cohort study that included the children from 0 to 18 years and young adults that were around 18 to 25 years with suspected hereditary kidney disease. We used whole exome sequencing. We targeted gene panel, like for nephrotic syndrome were included in 2, atypical HUS in 2, GLA gene analysis in 1, MLPA in 2, ciliopathy gene analysis in 1, and clinical exome sequencing in 2. And the variants were classified based on the ACMG guideline for standard interpretations. Talking about the results, out of the 33 patients, the most of the patients were distributed in the 1 to 10 years. and the adolescent and the young adult group. They were around 20 males and 13 females. In summarizing the frequency of diagnosis, in our study, the majority of the chunk was the glomerular disorder, constituting around 54%, followed by tubular disorder around 21%, cystic disease in 15%, ciliopathy 3%, and others as 9%. In glomerular disorder, the congenital nephrotic syndrome was number 1, was 5, atypical HUS was 5, SRNS was 2, Alport syndrome was 3, and C3 glomerulopathy was 1, and podocyte holding glomerulopathy was 1, and Fabry disease was 1. Tubular disorders, we have distal artery as 3, the proximal artery is 1, Bartter syndrome is 1, and stenosis 1. And ARPKD, we had 3 ARPKD cases, ETPKD 1, and Bartter-Biddle syndrome 1. And nephronophthisis constitute around 1, and in others, we have primary nephrocalcinosis as 1, and isolated renal glycosuria as 1. When we talk about the genetic testing, the pathogenic variants were detected in 2 and 4, and likely pathogenesis in 9. It constituted around 39%. BUS was around in 36%, and no variants were reported in around 24%. The most common type of mutation was the missense mutation, it was 90.5%, followed by the nonsense and the preemption mutations, and these splice type variants were not detected. Comparing the inherited our study with the other studies that has been done, the yield was around 39%, and the yield in the other studies were around 46 to 30%. In our study, the majority of the chunk was the glomerular disorders, followed by the tubular and the cystic disease, which was different from the studies in the southern parts, where the tubular constituted around 53.8%. So there was high diagnostic yield of around 93%, and the glomerular disease was predominantly in our studies that were around constituting around 54%. And most of the mutations were missense mutation around 90.5%. That emphasized that there is a critical role of single amino acid change in the kidney disease. And autosomal recessive patterns is around 53%. That signifies that importance of counseling to be done. So the limitation of my study was basically a small sample size, and we have a single-centered expert experience over 2 years.
Thank you, Dr. Ravi. What is the clinical implication of your study?
Sir, we wanted because the genetic data was lacking, particularly in this part of country. So the clinical implication is like, sir, in this study we have found that the glomerular diseases were whatever the cohort we had followed, the majority of the chunk was in the glomerular, followed by the tubular testing. So and out of which whatever the genetic testing we had sent, majority of the genes there was no variation that was no significant variation was detected in the glomerular chunk. So more of the clinical etiology associated with genetic testing is being required, specifically related to the glomerular disease.
Can you correlate with the history of consanguinity, especially in glomerular disease, where the major chunk was there? In how many cases history of first degree or second degree consanguinity was there?
So that I have to review, but around what can I remember is around 20 to 30% because there was significant consanguinity.
In your inclusion criteria, the hereditary kidney disease you included. Before sending the sample for genetic study, especially in the nephrotic syndrome, how do you come to know that this is the hereditary? I am not talking about the resistant or dependent cases of nephrotic syndrome. I especially mentioned that I am asking you, how do you come to know, especially in nephrotic syndrome, before sending the
Sir, apart from SRNS, if there is syndromic association, syndromic form of nephrotic syndrome, genetic testing.
Yes, that is apart syndrome or how do you, in nephrotic syndrome, how do you decide that? before sending to test?
So infantile and congenital nephrotic syndrome.
Yes, you find cases congenital nephrotic, that is the yes, you are same straightforward. But your inclusion criteria is.
Thank you.
You said your yield is 59%, right? Yield of genetic is positive yield is 39%. So your yield will depend on how liberal or how strict you are ordering this. So that's a bias. This is a retrospective study. Do you have a written protocol in the department that only these cases qualifies for sending genetic testing, or it was based on clinical judgment?
So clinical judgment.
Thank you. That's come to the end of the oral paper presentation. I will request Harshvardhan sir to please honor the judges. There are few posters who are not been printed, so I am showing that posters here. The judges for posters can judge here only. And I will request all the judges of the oral paper please come for the commento distribution. Photo, yeah. I will request Dr. Anand. We are going to have a quiz at 4:15 p.m.
By the time the next slide is getting loaded, I request everyone who is going to participate in the quiz, open up your mobile, open Google Chrome and type mentimeter.com, and just scroll through. We'll have a tutorial soon. So before that, just make it ready in your phone. Google Chrome, type mentimeter.com and just open up that website.
नेट का काम है ना करे नेट स्लो हो गया वो अपलोडिंग वो भी बंद कर दी वो तो जो अपलोड हो रहा था बंद कर दिया हो ही नहीं रहा
इसके बाद कर लीजिए दो मिनट में खत्म हो जाएगा
Good afternoon, sir. Can I start, sir? Good afternoon, everyone. Myself, Dr. Manjunath. I am presenting the my post is clinical profile and survival outcomes of pediatric acute kidney disease requiring renal replacement therapy. It's a retrospective study from the tertiary care center. So, coming to the background, so what is already we know that acute kidney injury is children is a life-threatening condition with significant mortality despite advanced renal replacement therapy. The aim of the study is to evaluate the etiology and the indications for RRT in pediatric AKI, identify the predictors of mortality and compare survival outcomes between hemodialysis and peritoneal dialysis. So the study is from Eastern India from Patna. Okay, the children aged from 1 month to 18 years who received RRT for AKI between Jan 2023 to December 2024. The measure is we use the AKI diagnosis by KD 2012 criteria. Data collected from demographic, clinical and lab variables, fluid overload and and comorbidities and moderate dialysis, that is HD or peritoneal dialysis, are also done the use of MODS. Statistically, we use univariate and multivariate equation for predictors of mortality and Kaplan-Meier for survival curves and cause proportional hazard regression in two studies to compare hemodialysis versus peritoneal dialysis outcomes. And coming to the main result, total we have entered 40 patients. In the 28 patients undergone hemodialysis and 12 patients undergone peritoneal dialysis. The most common interval for the AKI in our center is sepsis, that is 39.25%. So in mortality, 27.5% overall mortality. In that we have, you can see in the value plot curve, then now survival has higher overload, that is 16.8%, then survival of 8.3%. It is significant outcome of 0.003. And the predictor for mortality is no predictors were remained significant in multivariate analysis. And coming to the effect of intervention, hemodialysis associated with longer survival in the patients who have died, that is 88 days they have survived compared to the hemodialysis, compared to peritoneal dialysis at 22 days. And the PD associated with higher mortality, that is cost proportion hazard ratio 4.4 times higher than the peritoneal, higher than the hemodialysis. So coming to the limitations of study, total only 40 patients and retrospective design limit the solid interference.
So, what is the mean age of children who are undergoing CT and what is the mean age of
Sir, the mean age of the child is around 5 to 7 years. Sir, mean age of the child.
What is the mean age?
Sir, mainly have taken based on the hemodynamic status. If the child is hemodynamic stable, if they are good for hemodialysis, we have taken for them. If the child is unstable, for the patient we have chosen for peritoneal dialysis.
Age is not a criteria for a day.
Sir, age is not a criteria, but in the children less than 1 year, they are not compatible for hemodialysis. Sir. In the children, we have done peritoneal dialysis.
Have you compared the other baseline characteristics of HD group and PD group?
The other baseline characteristics like there is a patient is on sepsis, or then a patient is on hospital support. Other stats are also. You are choosing the PD, the patient who was more.
That's why I'm asking that. Have you put the message? Thank you.
Thank you, Dr. Shreya. Poster of Dr. Shreya, please. Dr. Shreya.
Good afternoon, everyone. Myself, Dr. Shreya. I am presenting a case of when the IGC. It is a case of infantile nephropathic cystinosis without any ocular manifestations. Cystinosis is a direct autosomal recessive disorder. It is a lysosomal storage disorder in the CTNS gene, which leads to lysosomal cysteine transporter defect, that is cystinosis, which therefore there is intra-lysosomal accumulation of the and crystallization of the cysteine, leading to multi-organ failure. The classic presentation of this disease is like they present as a Fanconi syndrome along with failure to thrive, and there is corneal cystine crystals deposition up to 16 to 18 months of age. This is a child who was presented to us with Fanconi-like syndrome leading to CKD at 4 years of age, but the ophthalmological examination repeatedly was normal. She was a 4-year-old female born of second-degree consanguineous marriage and came to us with polyuria polydipsia, and her ophthalmological examination was normal. She, on investigations, she had CKD with eGFR of 14 and severe metabolic acidosis with hypokalemia, hypocalcemia, and hypophosphatemia, and also rickets on examination. A genetic analysis was sent suspecting any tubulopathy or nephronophthisis. However, it came to be suggestive of CTNS gene pathogenic mutation, which was infantile nephropathy cystinosis. So for that, the child was started on supportive management. However, the specific therapy, that is histamine therapy, we were not able to start because of financial constraints and its availability. So here we focus on a case that even at 4 years of age, any patient presenting to us Fanconi syndrome can also have such, we should suspect, and this is an atypical presentation that the child's ocular manifestations were not there. Thank you.
So you are still following this patient?
Yes, sir, we are still following.
Follow.
Yes, sir.
What ophthalmological examinations?
Sir, usually these children have either crystal deposition in their.
How we see crystal?
Sir, either the crystal deposition can be in their lens, which can be seen on slit lamp. Otherwise, it can be seen by staining. But it was done repeatedly. But overall, the ophthalmologist is not.
It's seen by slit lamp, and below 7 years of age, it's very difficult to see by slit. So that's why it may not be that it's not present. And second, the site already has CKD.
Yes, sir.
In presence of CKD, you cannot diagnose renal tubular acidosis.
Yes, sir. Sir, actually, her history and the sibling, that the child, her brother was also having same symptoms, but however he was 2 years of age, and they both had the same history. Their evaluation initially, which we reviewed their reports, were also suggestive of RTA.
For the family.
Sir, we had done the genetic analysis of this child. We have done the counseling, but the father and mother both were not willing for further investigations.
Medication you learned?
So currently we are ongoing with the supportive management only. So histamine therapy, it's costly, and also the availability is an issue.
Okay, thank you, doctor.
Thank you.
Next, please.
Dr. Bhopkia Kansi.
Good afternoon, everyone. Myself, Dr. Bhopkia Kansi. I am going to present my case when red is not blood, that is acute hemolysis presenting as pigmenturia in chest. We all know red or brown color urine usually we can consider hematuria, but that close mimicker pigment, that is hemoglobin and myoglobin, can appear identical as gross infection. Hemoglobinuria mainly due to intravascular hemolysis when free hemoglobin exceeds haptoglobin binding capacity and excreted in urine, that leads to red color urine. The clinical importance is hematuria mainly due to urinary tract or glomerular pathology, where hemoglobinuria mainly caused by underlying systemic condition. We reported one case, 8-year-old boy presented with dark colored urine for 1 day. Otherwise, there is no history of any dysuria, fever, flank pain, trauma, or drug intake. And there is also history of upper respiratory tract infection 1 week prior to this episode. On examination, child had moderate pallor and mild itching, and there was no lymphadenopathy or organomegaly or edema. Initially, we considered differentials for hematuria, myoglobinuria, and paroxysmal nocturnal hemoglobinuria. And on evaluation, child urinary evaluation revealed strong dipstick positive for blood, but microscopy showed no RBC. And child having hemoglobin of 3.7, LDH of 1800, and indirect bilirubin of 12, and DCT is negative, and CPK levels within normal limit. And renal function of the child is absolutely normal. And the infective workup for tropical infections is negative. And we started child on intravenous fluids, and we given PRBC transfusion for severe anemia. And there is progressive improvement in red color urine we have observed. At the time of admission, child having red color urine, and at the time of discharge, that is around 4 to 5 days after admission, child urine is cleared after supportive management. Pigmenturia can be visually identical to hematuria, but represent systemic process like hemolysis. And urine dipstick alone is misleading in this kind of situation, and urinary microscopy is essential to avoid misdiagnosis and to prevent renal injury due to hemoglobin induced acute kidney injury. And the key takeaway point from this case is red urine in child is not always hematuria. A simple urine microscopy can change the diagnosis and save the life.
What diagnosis you made in this case? Final diagnosis?
Sir, post-infective acute intravascular hemolysis, post-infective. Sir, that levels are within normal limits, sir. We did G6PD. Sir, there is no previous history of similar illnesses, even after. Sir, this is 8 years child, sir. Previously. Sir, boy, sir, 8-year boy. After 3 months, we plan to repeat after 3 months of this PD. Yes.
Have you worked for PNH?
Sir, we plan to set PNH, sir, but parent.
Let's presume that it could be the post-infectious without excluding the other possible explanations.
Sir, attenders are financially not affordable. That's why we did not done PNH, sir, but we planned PNH profile.
So, to prove which infection or which mechanism led to post-infectious, so severe hemolysis of putting this child at hemoglobin of 3.7.
Sir, maybe, sir, we did that possible tropical effective workup, sir. That is
topic sweet clues in the urine, identification of a novel compound heterozygous SLC5A2 variants causing familial renal glucosuria. So basically, familial renal glucosuria or FRG is a rare condition which is characterized by glucose or glucosuria despite normal blood glucose levels. It is mainly caused by the variants in the SLC5A2 gene, which is responsible for coding the SGLT2 protein. So this condition is generally benign, but however, because of the persistent glucosuria, these individuals are predisposed to recurrent genitourinary infections. So here I present the case of a 1-year-old child, male infant, who presented to us with the complaints of recurrent febrile illnesses over 4 months, which were basically febrile UTIs. So, since it was fitting in the definition of recurrent UTI, we did the workup for recurrent UTI, in which the renal ultrasound and the MCUs were normal, indicating there were no cathodes, and immunodeficiency screen to done common antibody-associated immunodeficiency disorders were ruled out. But still the persistent glucosuria was present and at the time of interfebrile periods or during the sterile cultures. So there was normal blood glucose, normal renal functions, and no other tubular defects like no other proteinuria or amino aciduria was present at the time of presentation. So it resulted in a strong suspicion that there was some tubular disorder in which there is loss of excessive glucose in the urine. So we sent one whole genome sequencing where there was a novel compound heterozygous variant in the SLC5A2 gene, which confirmed the familial renal glucosuria. And thereafter we have done Sanger sequencing for parental segregation, in which we found that it was a maternally inherited variant.
So why have you evaluated the child for glucosuria?
So actually the child underwent urine RN. In that urine RN, in the dipstick there was persistent glucosuria. At the time of UTI, there was nitrite positivity. Along with that, there was persistent glucosuria positivity also. And when we did again repeat urine RN when the child's urine culture was sterile, still the glucose-urea was persisting. So that was a mystery for us, that why the child is having persistent glucose-urea despite having a normal RGS and normal HbA1c also.
What is variant of pathogenic?
So actually these variants are novel variants which we found. Initially they reported it as likely pathogenic. That's why we went for parental segregation using sampler sequencing, in which we found that the first variant, it was maternally inherited, in which basically there was missense variant leading to replacement of alanine to threonine, which resulted in the phenotype in the child.
And what about second variant?
So the second variant was an in-frame deletion variant. It was also present. It was present in the child, but it was not inherited. It was not found in the mother or in the father, likely indicating it was a de novo variant.
This is deletion, and you check for Sanger sequencing. It will not detect deletion. You have to do microarray.
Okay.
Or MLP.
Thank you. Dr. Malikarjun.
Good afternoon, everyone. This is a case from relapse to areflexia, a case of GDS complicating nephrotic syndrome. FRNX usually confined to renal system, but GDS is a rare complication or entity in complicating frequently relapsing nephrotic syndrome. A 3-year-old male with history of FRNX recently in remission presented with 15 days of inability to stand or walk with leg pain associated with bowel and bladder incontinence. On examination, there is hypotonia and hyperreflexia in lower limbs. On clinical evaluation, after neurological workup, initiated due to acute flaccid paralysis. On NCV, there is confirmed among variant of GBS. On MRI, there is nerve root enhancement supporting GBS diagnosis. Coming to the renal status, the child was in remission. Coming to the clinical course, due to severe weakness with huge disability score of 4, child was given IVIG 400 kg per day for 5 days. During therapy, child developed headache, photophobia and vomiting. We suspected aseptic meningitis and conservative management was given. Coming to the management, IVIG therapy, 400 mg per kg per day for 5 days was given and the rehabilitation was continued. FRNX was in remission without on tapering oral prednisolone with multidisciplinary follow-up, pediatric urology and nephrology clinics. Discussion: GBS in FRNX is a rare entity. Neurological symptoms may be overlooked in renal patients. Among variant, motor axonal involvement with normal sensory conduction consistent with NCB findings. IVIG therapy was the mainstay of GBS treatment with multidisciplinary approach.
So, when your patient developed GBS-like symptoms, from nephrology side, it was in remission. Okay. And the presentation was already 15 days duration. You started IVIG. After completion of 5 days IVIG, what was the result of this therapy late treatment?
Sir, initially there was no that much improvement. During follow-up, after 2 months, child showed improvement.
That could be effect of urologist therapy. So why to give in late presentation, use IVIG in late presentation?
need of highway. Already 15 registries, instead of doing MRI, yes, sir, you should have done CSL. It is also confirmatory, and you have already done MCV, you have diagnosed. You can support with CSL, there was no need of MRI registry. You have saved money for this. Okay.
Thank you, sir. Dr. Anandita. Last.
Good afternoon all. Today I am going to present a very interesting case of ANCA-associated vasculitis evolving from a different autoimmune disease, unraveling the mystery via genetics. So my case, we all know that evolution of one autoimmune disease to another is well reported in rheumatology and widely accepted that genetic predisposition is a factor in such cases. So my case is a girl who was born of non-consanguineous marriage. At 3 years, she was presenting with fever, acute onset paraparesis, diagnosed with acute disseminated encephalomyelitis. She was treated. She recovered fully in the next 2 months. But after 6 months, she again presented with bilateral visual loss. This time, she was diagnosed with neuromyelitis optica, and aquaporin 4 IgG was positive in serum. She was treated, but after that, for next 5-6 years, she had recurrent relapses. Every time treated with pulse methylprednisolone initially, and for this she was started on rituximab at the age of 5 years. And remission maintenance was done by rituximab 6 months to 1 yearly and MMF. And steroid was tapered and stopped in 2009. So after that she was in remission for 3 years, next 3 years. Then at 12 years she presented with features of diffuse alveolar hemorrhage, and there was microscopic hematuria also. Though anti-glomerular basement membrane antibody was negative, and scroll down. So this time she was treated, urine became clear of blood, but after 2 months she presented with features of AKI, with edema, hypertension and oliguria, and there was gross hematuria. This time creatinine was 1.17, so we did a kidney biopsy. Before that, I want to mention with these features, neuromyelitis optica developing diffuse alveolar hemorrhage. That time we went through the family history, which revealed 4th generation arthritis in the family on the maternal side. So at every generation, the presentation was earlier than the before delivery. So we did a genetic study. In the meantime, she was treated with, we started treatment. Kidney biopsy showed ANCA-associated glomerulonephritis, but with almost full house immunofluorescence, which is unusual in this type of presentation. And she has a very aggressive course, treated with pulse methylprednisolone followed by cyclophosphamide. Rituximab was restarted, but her renal parameters were worsening, so she had to undergo several cycles of plasma exchange, after which she showed improvement. In the next 11-month follow-up, she initially had remission, then again had a proteinuria relapse.
Question, please.
So,
So what is the indication of doing a genetic test in your case?
Yes, sir. With this unusual presentation, a neuromyelitis optica patient, basically an autoimmune disease of nervous system, suddenly labor up your pulmonary bleed and renal bleed. So we then went to the pedigree, which showed that 4th generation arthritis is there. So we
clinical possibility. What is the clinical possibility when you are ordered a test?
Yes, so we thought some underlying immune dysregulation is there, so we ordered the genetic test. And with that, ANCA-associated vasculitis immune complex deposition in the kidney, which was also unusual.
Can you name 1 2 diseases which you thought of at that point of time?
Pardon, sir?
1 2 diseases which you thought of at that time while checking that?
Yes, sir. There are few diseases of immune dysregulation which can have autoimmunity at the same time autoinflammatory, like COPA is a very new entity. That time it did not come to our mind, but SLE can have this type of presentation, early onset, and SAVI is another variety, and that can also have the type 1 interferonopathies. These usually present with autoimmunity in case of an autoinflammatory background.
Thank you. No more questions.
Thank you, sir. Thank you, ma'am. That becomes the end of all the poster and paper presentation. I will request Gopal sir and Dr. Harshvardhan to please honor our judges. Moving on, next we have the next sessions, the critical care nephrology symposium. And on the first session, I will ask Dr. Ridwan Ahmad sir as a chairperson. So he comes professor from the Indira Gandhi Institute of Medical Science. Dr. Sushil Pathak, assistant professor NMCH and pediatric intensivist. And Dr. Khushbu Rani, he is a pediatric nephrologist. And Dr. Samantra Rao, sir. I welcome Dr. Samantra Rao.
करना है क्या? छोड़ दे अभी तो अनाउंस हो गया है लोगों का फ्लाइट
From to everyone, the shortage of time and today's session is going to be given by Dr. Sumantra Kumara. He is the MD Pediatrics and DM Pediatrics from AIIMS Delhi, and he is going to deliver a talk on API. He is a renowned pediatric nephrologist, and his presentation is quite precise and effective. So, thank you, sir. Without wasting time, you have to carry the flight also. So, I think.
Thanks to the chairperson for nice intro. A very good afternoon and a post-lunch session. So, I will try for the next 10 minutes to keep you people little bit awake. First of all, thanks to the APNEICON team, particularly Dr. Gopal sir, and for this excellent hospitality in Patna. This is the second time we are coming for paid professions. So without any delay, I come to directly my topic. This is on API. First to start with anything for any topic is the definition, the classification, and then the details of that. So simple thing definition, because day in and day out, either a pediatrician or a nephrologist or a nephrologist sees API in the hand throughout the month, throughout the year. Maybe rightly or wrongly defining it, classifying it, but okay, there are always changing definitions also, so nothing is absolutely right or wrong in this thing. So to define an AKI as per KDIGO, this is any deterioration of the kidney functions which results in either an abnormal solute disbalance or any water disbalance. So to be exact, if there is an increase in serum creatinine by 0.3 in a time frame of 48 hours, or an exact elevation of creatinine by 1.5 times in a time frame of 7 days, or a urine output drop oliguria within 6 hours, more than 6 hours, that is called an AKI. So these time frames are later on added, that 48 hours and 7 days, and they are called separate categories. So we need to know for that. So coming to the history, so this is a simple question. So just to know the residents and the other senior doctors are still awake and alert and with us. So this is a simple question. We might have some topic like this for this one if it is correct. So a 3-year girl with puffiness and red urine admitted in a hospital. Creatinine was 0.4, seems to be normal for a 3-year girl on day 1, 0.5 on day 4, 0.6 on day 7, and 0.8 on day 10. So is this child is diagnosed? We don't have a baseline pre-moderate creatinine. So this is a AKI or a CKD or a AKI on CKD or a fourth new term AKD. Can anyone raise hand and give a vote for anything? No negative marking, only category for first prize. So, okay, we can deal subsequently, no issue. So category is pending. So this is a time span. So previously we are knowing that anything deterioration of kidney function over 1 month was AKI, more than 3 months was CKD, that was irreversible. Between 1 month and 3 months was a grey area. So the time duration of that 1 month has decreasing. So currently it is up to 1 week, not even 1 month. So anything deterioration between 48 hours to 1 week is AKI. More than 3 months is CKD. So in between 7 days to 90 days is AKD, acute kidney disease. Mostly they can be either AKI sequelae or they can be directly some people who are having very creeping creatinine, only 0.1 raising per 3 to 4 days, not satisfying the criteria of 0.3 rising of creatinine. They can from AKD directly go to CKD. So these are the points. The green bars significantly start when the creatinine start jumping. This red bar says within 7 days this is AKI, and this red bar to blue bar is again a window of 7 days to 90 days within the AKD period. So some of the patients very rarely can directly jump from AKD to CKD. bypassing API. So they have a very creeping creatinine of 0.1 or 0.2 per week for some reason. So we come to the classification criteria. So they are ever changing. Initially in 2004, the first definition was the classification belongs to rifle criteria, that is injury failure. We all know most of the veterans are used the term of ARF and CRF, acute renal failure. The term has changed to AKI because failure means last stage. So AKI is a variable term. It starts from mild, moderate, severe, not necessarily the last stage. So that's why the term is changed for better convenience. So the risk is 1.5 times higher of creatinine, injury is 2 times higher than creatinine, and failure is 3 times higher than creatinine. Parallel, we have given up to criteria also for 6 hours, 12 hours and 24 hours of urea. And remember, this 1.5 times will be within 7 days period and not 48 hours period. There is also loss and ESKD, that are the effect criteria of rifle. So changing to it, next came the APNEICON criteria in 27, where the stage are 1, 2 and 3, similar to that of risk criteria. The urine output criteria is exactly similar for both the teams. But what is changing here, the 0.3 elevation was required, particularly for smaller kids or pediatric age group, which is important. Next come to the KDCO criteria. Here the pediatric rifle criteria, which is changed to estimated creatinine creatinine, because for this rifle criteria there was a elevation for last times the pitfalls are the creatinine is always, as you know, a late marker. Your patient has a kidney problem now, the creatinine will jump by 48 hours or 72 hours. So we are 2 days or 3 days having a delay to diagnose AKI. And second, maybe we don't know most of the time the baseline creatinine. Before 1 month illness, how was the creatinine? Whoever tested, never less amount of creatinine as that value. So for these 4 criteria we go forward. We know that there is also for newborn. There similar criteria exist, but always the caveat is first 3 or 4 days where newborn creatinine are just reflection of maternal creatinine. But still we follow the similar guideline for newborn also. Here the urine output criteria is 1.0 and not 0.5 for the oligonucleotide criteria. So this is a little bit different. That difference we need to know and remember. So now creatinine is always not a great caveat, but most commonly used one. The best caveat might be costly, might not be well validated in adults as well as pediatrics. We'll come to that. So people are now trying to diagnose AKI more early, so that way we can prevent something, give less amount of nephrotoxic drug, give less amount of contrast to the patient if they are already at failure risk. So this is called subclinical AKI, where your creatinine is absolutely normal. Only some of the biomarkers that Dr. Raja was feeling yesterday was little bit high, can be NGAL, can be KIM, or any other markers that can be possible. So they have proposed a new classification for this one, where before this class 1 there is class 1 subclinical AKI, the first one, where the creatinine is more or less normal, only the biomarkers are elevated. And there are different biomarkers, most of them are not available, but cystatin, NGAS are available, might be in selected centers, still not widely available throughout the nation. So when comparing these 3 criteria, people have shown that for most of the time we have higher the grade, higher the mortality, higher the ICU stay. So we need to keep a tab on this one. So we can't adopt a single criteria till date. We can follow a combination of criteria every time. Chinese people have tried this PROC. They even told that you are over-diagnosing AKI. The creatinine which is fixed for suppose a 3-year child of 0.3, he can have a normal variation 0.3 to 0.5. So 1.5 times of 0.3 and 1.5 times of 0.5 is entirely different. So why you are over-diagnosing AKI? They have made this PROC and they have shown that people have already over-diagnosed most of the AKI which are not required. But this PROC criteria is not adopted by most of the centers still now. Because on one hand we are trying to say diagnose before your creatinine is jumping in subclinical stage, and the opposite side we are trying to say that always diagnose in a standard way where your treatment does matter. There is no solution yet for this PROC versus subclinical AKI. Other type of classification of AKI are on clinical basis. We know that on AKI there can be a decrease of urine output or may not be a decrease of urine output. So non-oliguric AKI also exists, as per the site of injury that can be pre-renal or renal or post-renal. How to diagnose differentiate pre-renal versus renal is in most of the criteria are not available to us as a point of care or site. So mostly we rely on blood urea is to creatinine ratio. So the urea is to creatinine ratio is more than 40 or the BUN of creatinine ratio is more than 20. Suffice our diagnosis of pre-renal AKI. So for pre-renal AKI, if all the criteria are not available for us, if we have doubt, we may consider all the AKI as pre-renal, can give a NS bolus if the child is not already a heart failure. We check if there is any urine output by either blood palpation or ultrasound or by catheterization. Even if there is failure of urine output, we can give a single dose of Lasix. And after 2 hours, if there is no output, we declare the child as increases renal and not pre-renal. And here it is also therapy for pre-renal also it is called furosemide stress test or the FST. So the incidence of AKI is not uncommon, it is around 30% for any ICU, maybe PICU or an ICU, and the mortality for severe AKI is also high, amounting up to 10 to 20% for both the cohorts. So always try to diagnose AKI. To diagnose early or not, we are not that sure, but probably most of the literature says try to diagnose it early. Whenever your markers are positive, that can be creatinine, that can be any other biomarker, try to decrease your nephrotoxic drugs whenever possible. So the take-home message is diagnosis of AKI is little bit difficult as per the usual biomarkers, but creatinine is widely available, though there are lab variations. Creatinine might be late marker, but we have the only choice now. Better to diagnose subclinical AKI till now what literature supports and try to take corrective measure on that background. So thank you, and on this occasion probably Sakila Mills details is shown nephrology condition of this month. I beg to remember you that we have an ISPN quiz this September end week for all postgraduates. Already names have been given, and this year also Eastern India has the highest number of participation of 42 among all the regions, and among them thanks to Dr. Anand, Bihar team alone has standalone participation from 13 different institutes. So thanks to all the East Zone, all the members for the success for ASEAN, and the continuing second year East Zone is participating in the maximum. I thank you organizer once more. I suppose I am not lost my time. Over to you.
Thank you, sir. As usual, your excellent presentation.
If there are questions, one or two.
Yes. Any questions from the?
Because it's very important.
Most welcome. Yes. This is one of the important topic. Any questions from the side is most welcome.
Maybe the time.
Okay.
Thank you, sir. Dr. Rajesh Srinath.
Next we have Professor Sir Rajiv Sinha sir. He is the head of Department of Pediatric Nephrology at Institute of Child Health, Kolkata. And welcome, sir.
Thank you. So I will start without wasting much time. So my topic is a bit different from the rest, like extracorporeal therapy in pediatric sepsis. So I would like to ask the audience if anyone can say what do we mean by the extracorporeal therapy in sepsis? Anyone? The trainees? Anyone? कोई तो बोले? हाँ? Extracorporeal therapy का मतलब क्या होता है? Dialysis. Somebody has said dialysis. So dialysis. Is only 80/40 on 2 anecdotes. The creatinine, which was initially 0.3, has gone up now to 1. And if you remember what Sumantra said, that the child is now in AKI. So AKI है, इसमें कोई doubt है नहीं. and the AK stage 2, the urine output has gone down to about 0.4 ml per kilo per hour आसपास, and the child is quite overloaded. So, how many of you think that this child requires renal replacement therapy? Put your hands up. ठीक है, at least 2-3 तो हाथ उठा. Good. So, why do you think the child requires renal replacement therapy? कोई एक बोले, जैसे सुमंत्र कैडबरी का ये प्रॉमिस कैडबरी, हम भी कैडबरी प्रॉमिस करें, बट सुमंत्र देगा उसको. So, why do you think that this child requires renal replacement therapy? Fantastic. So, I think we have achieved the main objective of this talk, that in the last 10 years, 15 years, हम लोग बहुत कुछ बातचीत करते हैं, but actually not much advancement has been done in the field of API, which has turned into practical aspects. So maybe in the next 10 years, with the biomarkers coming into utility, there will be more such of more practical knowledge. But what has happened is the acknowledgement of the fact that fluid is not good. This is one of the most important slides. I am very happy you already know that. That more you get fluid overload, more you are likely to die. And with the focus coming in, we did something more. This was supposed to play, and that was the reason that I was looking through this USB. But anyway, the first slide was showing the B lines, and the second panel was showing that despite the B line, the IVC was like a chink. So the child was fluid overloaded, but the fluid was not in the right place. It was all in the lungs. So what sort of dialysis do you think this child will require? We have got the whole range, PD से लेकर के CRRT तक. So what will be your choice? Anyone? Sir ji बोले slate. Anyone else? I think the answer will be, it depends upon lot of things. Depends on the patient size. It depends on the hemodynamic stability. It depends upon the availability. It depends upon the institutional expertise, and it depends upon the cost. But if we nullify all this, and if we say that I want the best for my child as per the KDIGO, CRRT stands first among equal. In this sort of a child with 2 inotropes, we can proudly say that we were among the first to start SLATE in pediatric in India, I would say. But we now feel that more than 2 inotropes in pediatric is very difficult, even SLATE. PD can be done, but we all know its problem. So, अगर मेरे पास सब है, then and the KDIGO also agrees that CRRT is the first among the equal. But CRRT is costly. Does Patna have CRRT in pediatrics or adult? Dose और बढ़ा दिए हम लोग 30 to 40 में गए, but is there any role of further increasing the dose? This is a common thing that happens, that the RO dose को बढ़ाओ, but at the moment the meta-analysis shows that increasing the dose of CRRT maybe is not that useful in sepsis. And the other thing which you have to remember is that increasing the dose of CRRT, you are also increasing the antibiotic clearance. At a high dose of 80 ml per kilo per hour, what is happening to antibiotic, we don't know. So here is you have to remember. Any other role for addition of extracorporeal device? This picture of Trump was given when Modi or Trump ka dosti tha, so most probably I should have removed it now. But yes, maybe there is a role for any addition for other extracorporeal therapy. If other extracorporeal therapy, the basis you have to is very simple, and I will try to simplify it as much as possible. Is that in sepsis, what is happening? Ganda cheez nikal raha hai. These bad things can be because of the bacteria, or that is called damage associated. That is a pathogen associated factors. And at the same time, while the body is trying to fight this sepsis, they are also secreting some things called dams. So PAMs and dams. These PAMs and dams are sort of like हम bomb फेंकना चाह रहे हैं on a terrorist group, but आसपास में कुछ normal आदमी भी मर जाता है. So it is sort of like that. Like dams are that the body is trying to save us, but at the same time it is secreting certain molecules which are not good for the body and causing hypotension. So the idea is that if I can remove these PAMs and dams from the blood, then maybe I will have some advantage. So how can that be done? Well, there can be heme absorption. Heme absorption means एक अलग सा circuit है. Circuit में that circuit will sort of absorb these PAMs and DUNS. This is something you might have heard is cytosol, or even we can auxiliaries can do heme absorption. We can go to the hemofiltration. We have already talked about CVVH, but we have already said that CVVH there is not strong evidence that high dose of CVVH is useful for removing these PAMs and DUNS. And then we can go for plasmapheresis for removing the PAMs and DUNS, but that also doesn't have that much of evidence. In fact, the American Society puts the evidence for plasmapheresis grade 3 quite low. So that leads to the absorption. Absorption can be to the auxiliaries. Auxiliaries is a filter which has got 3 layers. The first layer absorbs cytokine, second layer absorbs endotoxin, and the third layer is heparin, which helps in like anti-clot होने से help करता है. But auxiliaries का evidence at the moment is lacking. How about cytosol? Cytosol is so the advantage of auxiliaries is that it comes in a whole circuit, and in one circuit you can do CRRT, dialysis, as well as you can remove the PAMs and the DAMs. Auxiliaries comes in as a separate circuit, separate filter, not a circuit, separate filter. So you have to do a CRRT plus auxiliaries or slave plus auxiliaries. Auxiliaries absorb endotoxins, and at the present the studies say that it is good at removing interleukins. It is good at improving the blood pressure, but mortality outcome hasn't come. And pediatric it is restricted unfortunately to only this particular study of case series of 7. We have been using it for quite a long time along with other centers like I know Gangaram and in South May, but we haven't got the time to publish it yet, which is a shame. So we, in this particular case, we chose cytosol. Why? If you remember, we chose cytosol because this guy was already on CRRT. So we cannot use auxiliaries. If we are using auxiliaries, we have to change the whole circuit, and that's possible. So we chose cytosol. You can see the CRRT machine along with cytosol, and it seemed to work. But then we have to remember that one swallow never makes a summer. And we have to remember that this cytosol बोलिए या auxiliaries, they are removing bad things, but they might also be removing good things. There are a lot of debate when to start. Overall, there was a consensus statement, not a guideline. A consensus statement just published in the World Journal of Critical Care Medicine from an Indian group, which was saying that maybe starting cytosol early, within 24 hours, makes sense. But we haven't really got the idea. Now, this is some of the criteria, like high use of anotropes, high interleukin, high procal, and they have introduced something called a cytosol score. This is the cytosol score. You can get it from the online, and you can use it. But again, pediatrics में there are not much of evidence. So I'll just end up with our own experience. This is a combination of Apollo and ICH. At Apollo, we are using the Prisma Flex, and ICH we have recently, early this year, got the new machine, the Prisma Max. And overall, we have done about 34 children who had CRRT, and the main cause of the CRRT was, as you correctly said, was fluid overload. And 5 of these children had sort of 34 tail. So 5 used cytosol, 5 used oxalis. And overall, there was 2 survived, 3 died. So very small cohort. One thing that was found out was that with the use of cytosol, there was a drop in interleukin 6. So ये तो हम लोग को मालूम है. But it is a too smaller cohort to comment on further. But hopefully we can try to combine this, and I owe this slide to Pallavi, or all the last 3 slides. So, in summary, what did we learn? We learned that extracorporeal therapy has a role to play in sepsis. Number 1, as a CRRT to remove the fluid overload, stabilize the child. Number 2, maybe for using the endotoxin. Maybe we can add oxalis or a cytosol, and that can be useful, but we really need more and more evidence for it. Thank you very much.
So, thank you Dr. Rajiv for your very informative and nice presentation. You can take few questions.
So, my question to the first speaker. So, my what is your protocol for a follow-up of a child with a pediatric API? I mean, how do you follow? What is the protocol which you follow at your center?
Good question, sir. On the due to lack of time, I have seen a frame only, but not discuss on that. On any child with AKI, we know the follow-up is lifelong because there are 4-5 outcomes of the graph. AKI child can recover completely and never ever any kidney problems. They can recover completely, and after 2 years or 3 years, they can again go to CKD. AKI child can have partial recovery, and this is CKD on it. Partial CKD stage 2 or 3, and later on advanced. Otherwise, AKI on that day directly goes to CKD and stage. So that's why even if the child is absolutely 100% recovering, the follow-ups are for lifelong. At least for pediatrician is for up to 18 years. And usually the protocols, though not robust, at least every 2 to 3 months we need to check the parameters, blood parameters. Or hypertension at the time of discharge. The point is that what you should do with those who have got the normal thing at the time of discharge. At the present, KDIGO guideline says, be it adult, be it pediatric, they should be seen up in the clinic at 3 months. At 3 months, you do a proteinuria or albuminuria, you do a blood pressure, and then you decide. And if it is high, then they follow up with the nephro. But if it is even normal, then also the general physician or the pediatrician, as Sumanta said, should be following them up.
Okay, so can I ask one more question? So my question to you, Dr. Ali. So you work in a government center as well as you are working in a private setup also. So the cost of your cytosol in a government center, so how do you manage that? So what is the cost? That is the reason I because practically what I can infer from your slides or from the literature is that anybody, practically anyone who is in a septic shock, you know the outcomes are better. This we know. So how about the cost?
So if we are doing a cytosol from in a private, it's 1 lakh. Now in our setup, अगर हम लोग ज़्यादा रोते हैं, then the company gives us 80,000. Since we have introduced CRRT, we are not using cytosol that much. We are using auxiliaries, and we have got an NGO who funds for 1 cycle. After that, so that's why how Pallavi presented that somebody asked that what happens after the first cycle and it's clogged. So Bhagwan Malik है या जो लोग का पैसा है तो है.
Sir, just to add a little bit, because in government setup also in our Western Mall, Calcutta Medical College is doing under government setup. They have done 5 such on auxiliaries. So they have not published anything yet. But they are free of cost. But probably that sir, the supply is often on and off. Anytime the government have a fund issue, the supply will be off. But whenever it is available, you can use that for that.
Next challenge is a
Right.
we have stress biomarkers, structural biomarkers, and functional biomarkers.
Right, sir.
What you advocate for API? Because we have 3 types of biomarkers.
Right, sir. There was a snapshot of that one also, which was asking, yes, sir. Complete the question.
One is a structural and functional.
Right.
For API, every diagnosis, which biomarker you advocate?
Right. Excellent question, sir. I think it's tougher question for most of us. So I have a snap of that one also. Some of the markers are acting on PCT, some of the markers are acting on glomerulus. Mostly our markers are mostly on PCT that we are working. The mostly studied in pediatric age group is NGAL. Either it is a blood or urine. Cystatin C and key comes second and third position as per available literature. So in India also, from our center also medical college, we have a study on urinary NGAL to study AKI, to diagnose AKI early. So NGAL is, as you know, is a tubular marker and they directly act on tubular function. So for glomerular marker,
NGAL has been now approved by the FDA as one of the biomarkers. So future may already they have published a study from Cincinnati. Cincinnati is one of the like mecca of pediatric AKI.
So now in adult patient there is a nephro check which has been validated.
Yeah, for adult the nephro check has been validated. And in pediatric from the Cincinnati group, they have validated NGAL. And what they have published is something very remarkable, but it has to be proven in our setup. That is just based on NGAL. They are initiating CRRT very early in PIC, just based on NGAL. And they are showing that it is cost effective.
Okay, thank you.
Thank you.
Now, thank you, Dr. Sumantra and Dr. Rajiv. Yes. Thank you very much.
Thank you, sir. Thank you, all the chairperson. I will request Chancellor sir to please honor our chairperson and the speaker. There is slide change in the program. We are going to read the Mentimeter quiz, and after that we will continue with the scientific session due to some flight issue. So sorry for that. I will request the Mentimeter team and Dr. Sumanta Rao and Lavji Bose to come on the dais.
By the time it gets loaded, so I am requesting all the participants to open your Google Chrome and download and go to livemedical.com. I will also play along with you. Have you all opened up in your mobile? It should look something like that. Everyone is having this screen. All of you are having in English, English version, or someone is having German also? No. Okay. So we'll give a small tutorial followed by a trial round. After that, the final round. Okay. So we should all understand this website. You don't need to download any app. It is played by this website only. It is very easy. If you open it up, you will find enter code to participate in Menti. You don't need to click anywhere. Just follow it up. Are you getting this message? Enter code to participate in Menti. Everyone? Anyone not having this code? Have you all opened Mentimeter in your Google Chrome website? Anyone having any difficulty can raise your hand. Remember, your mobile signal is very, very important. If it is weak,
So it will get loaded very slowly and you might be out of the race. So all of you have opened it. You don't need to, sir. This is just a tutorial right now. You don't need to enter any code. First go through with the whole tutorial, get acquainted with the system, and then I will provide the code. Don't worry, sir. So we'll give you a code, and they will also ask you to enter your name. Please put your whole name in that bar. Don't use any nickname, because the first and second will get prizes, and that name will help us identify you. Don't use any nickname. Right now you don't need to do anything. I will tell you when you are going to do that. सब कोई open कर पाया ना? क्या मेरे अगर इसको Mentimeter open नहीं हुआ तो please हाथ उठाइए. So सबका open हो गया, right? So we went to Mentimeter, we opened it, and just wait. Don't need to click anywhere. So no code given. Yes, a blank space. You have to enter your code. Don't enter your code now. You don't need to enter anything right now. Just get acquainted with the process. So you will enter your full name, and then you will wait for the quiz to get loaded. Then from here I will start the quiz. Do not press any reload or join another quiz. Just wait. When I will start the quiz, I will let you know. Okay. Quiz is for all. It is for everyone. Everyone. Don't need to press join another quiz or reload. And if you are lagging behind, probably it will be your network issues from your side. Because if you are having poor signals, then it will load quite late. And then eventually you will have the questions here as well as in your phone. I will read out the question and you will have the answer. It will be and this kind of a question, this kind of a screen will appear in your mobile, and you will click any one out of 4. If you miss to click, then you might get this kind of a screen that you didn't vote in time, or wrong answer, or loading result. But remember, don't need to click the refresh button. If during the quiz, if you click on the refresh, then you will be out of the race. Okay? And at the end, you will either get a wrong answer or a correct answer, and then we will show you the result board. Okay? So don't click back button. When you are out of quiz, you cannot re-enter. Don't click back. Yes. So we'll start with a practice session first. Just wait. Have you told the code? Yes. So this is the code, right? So this is the code you type. I will also play along with you. It is 21442314, and click on participate, and then don't click anywhere else. Join. Click on join. Left upper corner. Then enter your name. You will get this screen. Enter your name. I am also playing the same along with you. 14 players ready. Enter your name. 22 ready. Your full name, not any nickname. And then join quiz. Yes, good. 27 players have already joined. Very good. 28, 30. Anyone else having any issues? This is just a practice session, right? This is practice session. Everybody okay? Any lag in the internet or something? Already 30 players have joined. Majority having any issues, or only a handful of people are having it? 21442314. The code is being shown over there. This is our problem. Can raise hand. Any problem with joining? The code is 21442314. Before I start, all have joined, I guess. You have joined? Yes. Have you put your name? Put your name. Do not put any nickname. Put your real name. I think everyone has joined also. Okay. So I am starting the quiz. I am starting the quiz route right now. This is just a trial. What comes after the letter A?
1. We start.
What comes after the letter A? your options will be in your screen only. Just click and just click the options and then don't put any refresh or something like that. Just wait. So just not only right answer but rapid answer, because the score is the accumulation of your right answer plus rapidity of time. Yes. If 10 candidates are answering right, whoever is answering is fast will get a first prize. Yes. Only one. And that is me. No. So next, question number 2, trial. Ready? I'm going to start that, okay? Okay. After January comes, which month? The time starts now. एक से ज्यादा गलती है तो लोग सीख गए मतलब देखते हैं कितना गलती है so time up yes सबसे सीख गए very good चलो fine and at the end the result will look something like this demo this is for a demo just a demo of demo category okay so can we start here so all of you are now confident dealing with this mentee so on the same link or we need to change the link okay so again you re-entered your mentimeter.com again so back right back and just don't need to reload it you can reload it as well you have to go to your again the first home screen mentimeter.com so like this mentimeter code number I will provide you first go to your ओरिजिनल अगर फर्स्ट पे आता है तो डायरेक्ट कोड नंबर एंट्री होगा अगर नहीं आता है तो ज्वाइन अनदर यूज करना पड़ेगा ओके दोनों टाइप का स्क्रीन आ सकते हैं जैसे मेरे स्क्रीन में दिख रहा है डायरेक्ट कोड एंट्री करने का चांस दे रहा है वो यस जूमिंग सो एंटर कोड टू जॉइन द लाइव मेंटी किसी को प्रॉब्लम है एनी प्रॉब्लम नो वेरी गुड किसी प्रॉब्लम है हो गया नहीं चलो तो हमारा ही जैसे लाइन में इसका तो प्रॉब्लम है
क्या हुआ कुछ दो वहां से तुम अभी यहीं बैठ
अरे भगवान ऑल का वाईफाई थोड़ा सा लो था
अभी
जस्ट वेट
क्वेश्चन दिख नहीं रहा है तुम यहाँ बैठ जाओ चल सामने बैठ जाओ सामने से आ रहा है अब आ जाएगा देखो
डेमो तक तो ठीक चल रहा था यही होता है देखिए डेमो तो अच्छा होता है जब करने जाते हैं कहते हैं रुकता नहीं है ठीक हो जाएगा नो वरी विल डू दैट गोपाल से बोला तुमको ऐसे एक तुम सर्किट वैसे खेलो थोड़े तो एंजॉय द शो डेमो at least right price size virtual नहीं है I think Gopal is not there but price are real first and second prize for residents as well as देखते हैं चलो no I will share the code wait yes so this is our code 62311351 everyone please put that code and join quiz great Repeat once more.
Good.
One more repeat. 6, 2, 3, 1.
1, 3, 5, 1. It is showing in the top. Good. Already 25 players.
6, 3, 2, 1, 1, 3, 5, 1.
Yes, 5 to 6 players remaining, I think. 32 players. Everyone, I think, have joined.
So get ready to play.
Are you ready now?
स्क्रीन में आ रहा है ready?
किसको प्रॉब्लम हो रहा है?
Please raise hand. किसको प्रॉब्लम हो रहा है तो raise your hand. Can we start? Okay, fine. बेटा प्लीज टेक
तुम्हारे लिए अलग से
तुम्हें हम लाइन हो बेटा थोड़ी देर के बैठ जाओ
34 players ready.
Only 34.
35.
प्राइस चाहिए नहीं चाहिए?
If you say, then I will start.
Start.
Ready? Okay, chalo.
Here we go.
Expected bladder capacity of a 7 years old child. The answer will be in your screen.
Try to answer as quickly as possible.
Fastest finger first, just like KBC.
Time up. So 8 plus 1 or plus 2 into 30, right? Copper rule.
Next, ready? 34 players ready. Now, you will get an image along with that question. This is an image of a food. 7-year-old girl with frequent relapse nephrotic syndrome developed a skin rash on a steroid sparing agent for the last 8 months. You have to name that agent which have caused this kind of skin rash, already covered in the lectures multiple times.
2 seconds remaining. 1 second. Time up. So it's cortisol, it's ANCA mediated skin lesion, mostly due to cocaine overburden.
Ready for the next question? Here it comes. Nine-month, 10 kg child with sepsis API on PD. Fill volume 30 ml, 30-minute cycle. Day 2 sodium rose to 168 from 145. The next PD fluid change needed at the initiation.
also. Answer is in the picture itself.
Absolutely.
Time up.
Excellent.
Very good.
Excellent. Excellent.
So upper quantity lands up in lower one, lower drainage with a ureterosteel and a blockage stenosis and dysplastic. Okay. So this is weaker relaxed law. The opposite is Stephen law.
So next question. Here it comes. Child with spina bifida and neurogenic bladder has recurrent UTIs despite prophylaxis. Most useful preventive strategy is. Rajesh sir has already emphasized on it, and so did other speakers. Excellent.
Excellent. Here it is the answer to be started as early as possible post birth. Antibiotic tolerance may not at all needed. Forget about IV. Even oral antibiotic tolerance may not be needed. The child is having less inflammation.
So the next question. Two months asymptomatic girl, 19 hydronephrosis, right kidney, postnatal USG, right pelvic diameter, APD is 20 mm, no hydral ureter, bladder normal. Next imaging modality. MCUG, CT scan, EC scan, DMSS scan. 4 options.
No, this one थोड़ा water लग गया. So ambulance hydrolysis for hydrolysis we needed functional study, not structural. We needed DTPA. The other versions of DTPA are LLEC or MAC3. So LLEC is the answer.
Next
one of the product listed मिलेगा नहीं?
Question number 10 out of 15. Ready. Four-year-old girl with first episode of uncomplicated UTI and normal USG. So what has to be done?
मीटर में मैंने टॉपिक बताए थे, अगर आप लोगों को याद होगा तो.
Yes.
Yeah. Again, correct by most of them. So no further investigation for more than 2 years and first UTI with normal ultrasound. No further investigation required if no prior LUTS.
So next question. This is question number 11. 7-year-old girl with HUS, persistent anemia, thrombocytopenia, AKI, despite supportive care, genetic test, CFH mutation positive, best treatment. Which molecule?
So time up.
Good.
Right, correct. Equilibrium.
Perfect.
And the knowledge is also currently available in India, but though the price is little bit exorbitant, but still it's available.
So ready for the next question. Most common histopathological lesion in SRMs is.
Wow, everyone has voted, no one has missed. Very good.
Lovely.
Correct answer, FSGS. So it is only marginally high, just 49% and 47%, but still it's marginally high FSGS. Second is NCD and least is Mespidian.
So question number 13, here it comes. We are already in our slow-goers. Which of the following is an indication for kidney biopsy in a child with nephrotic syndrome? Oh, excellent, excellent.
When you are straightforward question.
Straightforward. So we have 2 balls to go. Last over, 2 balls to go. Question number 14. Are you ready? Here it comes. Which pathogen is classically associated with stool white stones and alkaline urine in a pediatric UTI? This is from our PG institutes.
Excellent. Yeah, very good. Very good. Excellent. Very good. Very good. Excellent. So last question. So the last ball, last question of our session. Let's see. All of you are ready? So here it comes. Most important predictor of mortality in pediatric AKI is azotemia, fluid overload, hyperkalemia, acidosis. This is the last question. 5 seconds to go. Everyone has voted. Very good. Excellent again. Excellent. Correct. So fluid overload is the most important factor to address during AKI. So all of the reasons for that. We attended the AKI lectures. So now we don't know what is the final result. So it is a big clap for Dr. Nilati for successfully commenting this one and giving this short time. Big clap for everyone who has actually participated and made this thing very smooth. Ready? So let's see what is the final result. I don't know. So we is ALS now identified. Cell now next. नहीं वो नहीं है ठीक हो गया मिला थी next is Utkarsh Srivastava. Excellent. Resident. So resident. So you are first from resident part, right? 2 prizes are from resident. Utkarsh first prize. Then may I know who is Anand Kumar Gupta? And then who is Papi? Who is this nepotic guy? Who is Papi? Okay, Ananda. Who is Lippy? Who is Lippy? Angioedema Lippy. Who is Lippy? Huh? Prize will get prize. लिपि नहीं है कोई. Second is NGU. So I told you to put your exact name actually. Who is NGU? Pingu. आप है. Shreya Mehta. President. उतना बात पड़ेगा. First and second from resident category. For Patna. I have a very pleasant duty to invite Dr. Mrityunjay, who has been my student and now he is additional professor and head of pediatrics in All India Institute of Medical Sciences, Raebareli. And he has got areas of interest like nephrotic syndrome, pediatric AKI, pediatric vasculitis. And we have papers together
Come on, Dr. Mithunjay. Excuse me.
Yeah, it's coming. It's coming.
I think your subject is success-induced AKI. I think it's very important for all of us.
So good afternoon to everyone, and until this slide is getting loaded, first I would like to thank the organizers for giving me this opportunity to be the part of this excellent scientific meet. We have a very engaging scientific session over the last 2 days, and it's my privilege and honor to be in front of my mentor, Professor Nigam sir. I think I learned ABCD of pediatrics under him, so I can feel very proud myself actually right now that this session is being chaired by sir himself. And so I'll be discussing a little bit about sepsis-induced AKI in next 10 to 15 minutes. This slide is not getting loaded.
In the meanwhile, I will be telling about Dr. Mithunjay. He is a very talented personality. He has a lot of virtues, which you all don't know. I've been somebody who follows him on the Facebook can know about his virtues. So out of the academics, he has got a lot many hobbies.
Sir, I think the leisure time, I try to spend some time on music. That's my passion. So,
In Raebareli, you have now 3 medical colleges.
no, sir. Raebareli, we have just one institute, AIMS. It's placed 70 kilometers from Lucknow. So Lucknow has got 3 institutes, including KGMC, SCPGI, and RML. So it's around 70 kilometers from Lucknow. Yes. And in UP, we are having 2 AIMS. One is Raebareli and the other is Surat.
In Raebareli, you have no other medical college?
No, sir. It's only AIMS. Yeah,
Oh, I was getting confused.
Yeah, Bareilly is different, sir. Bareilly is rested UP.
Bareilly is famous for Jhumka Girare. Bareilli ke bazaar. So that is different than Raebareli.
Yes. Yeah, so it's finally there, I think. Thank you. Yeah. So I'll be discussing sepsis-induced AKI. A lot of things have been discussed already about AKI. So I'll be discussing just things which are relevant to sepsis-induced AKI. And I'll be quoting evidences from just last 4 to 5 years. In all my slides, you will see references from last 4 to 5 years papers, and which are relevant to only sepsis-induced AKI. So I will try to be very specific about this presentation. So in next 10 to 15 minutes, I will be discussing about epidemiological burden of pediatric sepsis-induced AKI, the changing definition and pathophysiology, RT detection tools like sepsis renal angina, renal angina index, biomarkers, role of point of care ultrasound, what are the evidence-based management strategies, a little bit about the role of extracorporeal therapy, although it has been discussed in the last session. And if time permits, I will discuss just a little bit about role of precision medicine in the future management of sepsis-induced AKI. So a little bit about the background. Majority of AKI is contributed by sepsis, and it has been seen in studies that 25 to 40% of children with sepsis they develop AKI at some point of time. Presence of severe AKI triples the mortality risk, and the highest stage of AKI, especially stage 2 and 3, are associated with higher mortality, longer length of stay, and the need for renal replacement therapy. And severe AKI has been independently associated with death or new moderate disability. It has been proven in multiple studies now. And you have to remember that sepsis and AKI is a two-way street. Now we have evidences that suggest that AKI itself increases the risk of sepsis as well. And the most famous awareness study that suggested that early identification of modifiable risk factors for AKI decreases the morbidity and mortality. So when we discuss about epidemiological study, the most important landmark study that comes to our mind is AWARE study. It was a prospective multinational study conducted over more than 4,600 critically ill patients. And what they found that about 27% of them developed AKI and about 12% developed severe AKI. And the presence of severe AKI increased the death risk by day 28 and plus the increased use of mechanical ventilation and renal replacement therapy. There are more existing data on this and it suggests that about 25% of hospitalization with pediatric septic shock had AKI and it was associated with more than 3 times increased risk of mortality and need for renal replacement therapy. The definition has been changing over the years, and conventionally sepsis-associated AKI has been defined as occurrence of AKI within 7 days of sepsis onset. It has been divided into two obvious phenotypes. One is sepsis-associated AKI, where the direct mechanism related to infection or the host response, or indirect mechanism driven by sepsis, treatment or sequelae that leads to AKI, sepsis-associated AKI. And another phenotype is sepsis-induced AKI, which is a sub-phenotype of sepsis-associated AKI, where sepsis-induced mechanism drives kidney damage directly. For sepsis, as pediatricians, we have been using the Surviving Sepsis Campaign guidelines for defining sepsis. But in last few years, new criteria has been laid down, like Phoenix criteria, and it has been seen that the Phoenix criteria it has outperformed the SIRS-based definition that we have been conventionally using for defining sepsis. In adults, we have sepsis 3 criteria, but that has not been validated for pediatric age population. So this is the Phoenix criteria for sepsis. I will not go into the details. For AKI, we still use KDIGO criteria. There have been flaws which have been noted, but still it is the most universally recommended and validated guidelines that has been that is being used for defining and staging pediatric AKI. So where pediatric AKI actually differs from adult AKI is actually the pathophysiology. So what happens in other forms of AKI is macrocirculatory dysfunction, including hypertension and shock, that contributes a lot to development of AKI. However, in cases of sepsis-induced AKI, it's not a macrocirculatory dysfunction, but this whenever there is sepsis, it actually triggers a cascade through this pathogen-associated molecular pattern and damage-associated molecular pattern, and ultimately leads to release of exotoxins, endotoxins, and cytokines, and which ultimately leads to a lot of processes, including immunomodulation in the host, inflammatory response, complement activation, renin-angiotensin-aldosterone system dysfunction, mitochondrial dysfunction, metabolic deprogramming, microcirculatory dysfunction, and macrocirculatory alteration. And it leads to multiple subphenotypes or endotypes of sepsis-associated AKI, because that helps in understanding what is the role of precision medicine and deciding upon the different strategies that we use for different phenotypes of AKI. What message I want to give you that in sepsis-associated AKI, you need to understand, even if the child is maintaining a systemic blood pressure and perfusion, then also he's having a risk of developing AKI because of these multiple mechanisms which are actually contributing to the development of AKI. So early identification of AKI is very helpful, and we have now multiple risk stratification tools. We have been using renal angina index for a quite long period of time. For sepsis-induced AKI, we have now a modified sepsis renal angina index, where actually what we use, we take multiple risk criteria and injury criteria. Risk criteria like PICU admission, history of transplantation, mechanical ventilation, and like injury criteria for like rising creatinine or fluid overload. We multiply it, and this score of 1 to 40 is, so once we have an RI more than 8, then it has a very high positive predictive value of AKI. But this, when we add this platelet count, which has been modified recently, when we add this platelet count to this existing renal angina index, it becomes sepsis renal angina index, and it has been observed that it has got a very high predictive value for developing predicting sepsis-induced AKI in children. And it is independently, a high sepsis-induced ARIA is independently associated with adverse kidney outcomes, including need for kidney replacement therapy. Another serum biomarker that has come into the domain is serum renin and prorenin. In normal state, renin, prorenin and renin leads to activation of angiotensin 1 to angiotensin 2 through ACE. But what happens in sepsis-induced AKI, because of endothelial dysfunction, its ACE level is decreased, and because of this negative feedback dysregulation, the level of renin and prorenin is increased. So it has been seen a patient who is at risk of developing sepsis-induced AKI has got a very high level of renin and prorenin at the time of ICU admission. So indirectly, if you don't have the access to these costly biomarkers, you can go for the serum renin prorenin level to predict AKI, and it has been observed that concentration of these renin and prorenin and they trend over next first 72 hours predict severe persistent AKI and mortality. Now, a lot of studies have been done in last decade on urine biomarkers, and still we don't know it's a hype or hope. But there are multiple biomarkers that have studies. There have been previous presentation also which has covered these biomarkers. NGAL has been most widely studied as discussed in the previous presentation. But NGAL actually has performed very well for other forms of AKI. But when we talk about sepsis-associated AKI, it lacks specificity because it has been observed that NGAL is secreted not only by the tubular epithelium, it is secreted by neutrophils and liver as well. So whenever there is a sign of inflammation or infection, then NGAL rises. So NGAL actually fails to differentiate between AKI due to some other causes or AKI due to sepsis. So it doesn't perform very well in case of sepsis with AKI. Like other molecules like KIM1, NETRIN1, and there are cell cycle arrest markers like TIMP2 and IGF-BP7 and IL-18. TIMP2 and IGF-BP7 as has been discussed earlier, it is used in NephroCheck. It has been approved by US FDA for adult population. However, their use in pediatric population needs to be validated. This is one study which is published recently in Frontiers in Pediatrics in 2022, where they compared these three biomarkers, interleukin-18, IGF-BP7 and KIM1, and what they found that these three biomarkers were significantly high in patients with sepsis as compared to those without sepsis, and the level of urinary IL-18 was having high sensitivity and specificity, as the area under the curve was 2.92, which was very high as compared to KIM1 and IGF-BP7. So at this point of time, IL-8 appears to be a good biomarker which has got a future role in diagnosing and predicting sepsis-induced AKI in children. NephroCheck as a tool, which has been approved by US FDA in adults, but its use in pediatrics needs to be validated in due course of time. Then coming to sepsis biomarkers, there have been studies like Persevere 1 and Persevere 2, which is a pediatric sepsis biomarker risk model. There are again multi-biomarker risk model which has been used for predicting sepsis outcome. Why I am telling you? Because there is a trend of using these sepsis biomarkers with AKI biomarkers, and then thereafter you can decide upon the precision medicine for selected phenotypes. So it has been seen that these multi-biomarker risk model, they have got positive predictive value of mortality 32% and negative predictive value of 99% in patients who are having sepsis. Another tool we have having is point of care ultrasound, and we have got one index called renal resistive index. It's a very simple parameter which is measured by Doppler ultrasonography, and it has been observed that increased intrarenal vascular resistance secondary to vasoconstriction is one of the earliest changes observed in sepsis-associated AKI, and the RRI cutoff of 0.71 for 1 to 4 years and 0.69 for 5 to 12 years have a good discrimination for predicting AKI on day 3 of children. So, and it's a very important revolution that RRI was observed to have a similar diagnostic performance as urine and gal to detect AKI. So the message is, if you don't have access to these costly biomarkers in your ICU, if you have a point of care ultrasound access, you can simply go for this RRI, which can help you in predicting this sepsis-associated AKI in vulnerable children. Now, when we come to management starts with prevention, and we are using this bundle approach, which is recommended by surviving sepsis guidelines, where we start with systematic screening of sepsis, followed by antibiotics as soon as possible, preferably within 1 hour with shock, and less than 3 hours if organ dysfunction is without shock. Fluids, again I will discuss a little bit about fluids. Fluids need to be individualized and based on responsiveness. We have to follow this pattern, like early vigorous resuscitation, followed by stabilization and de-escalation, because fluid overload has been found to be an independent predictor mortality in multiple studies. And when you feel that the patient is not responding to this statin, then you have to think of vasopressor when the patient is found to be fluid refractory. Apart from that, we have to think about preventive statins like Ninja and like nephrotoxin in you have to use judicious use of nephrotoxin to prevent the patient from nephrotoxin-induced AKI, and to maintain a MAP for age, that is 50 to 60 years in time, to target MAP to maintain the systemic blood pressure. Now, when it comes to fluid choice for resuscitation, again there is a lot of studies, and most of the recent evidences they lean towards balanced crystalloids. Now, people have stopped using normal saline as a resuscitation fluid of choice because of very high chance of hyperchloremia. And most of the studies you can see, because these studies are from last 4 to 5 years, and they have concluded that use of balanced crystalloid, it is associated with decreased major adverse kidney event at day 90 and very low significant difference in the mortality rate. So this is the one study which is published in BMC Pediatrics in 2025, this year only, and it's this systematic review and meta-analysis in pediatric septic shock, and what was observed that balanced solution was associated with lower need of RRT and a reduced occurrence of hyperchloremia. So clearly we have an edge, we have a evidence leading towards balanced solution, and there is no doubt that we need to use now Ringer's lactate or Plasmalite, whatever is available in your setup, to use as a first line resuscitative fluid of choice. Now, fluid overload, again, as I told you, it's an independent predictor of mortality. All good setups, they should have daily and cumulative fluid balance monitoring to optimize fluid management strategies. And in studies, it has been quoted that fluid overload more than 15% is an independent predictor of mortality. You can use either of these calculations, either by fluid in minus fluid out divided by weighted admission, or you can use a rate this criteria, and you can calculate exactly what the patient is and how much overload, and then you can titrate the fluids accordingly. There is a trend of using biomarker directed fluid management where people have used these biomarkers and gas. If you don't have CRRT, you can use SNET, which is a gentle modality hemodialysis with a slightly low blood flow rate and dialysis flow rate. Now, again, there are a lot of controversy about early versus late RRT, and in most of the adult trials, this FET trial, this ideal ICU trial, START-AKI trial, they failed to show benefit of early RRT, and they didn't show any good outcomes when we looked at MAKE 90 or mortality. One trial, Million trial, they showed some benefit, and it showed that there was early RRT improved the 90-day survival. However, there is one study which is published in JAMA in 2024. They looked upon the pediatric population. What they found that the longer time to RRT initiation was associated with greater risk for major adverse kidney event at day 90, in particular mortality. So you need to be cautious, and you have to think patient, and you have to use judicially and correct time to start the RRT. It should not be too early, too late in pediatric population. The outcome, again, sepsis associated AKI was found to be with a worse outcome as compared to those who are not having sepsis. There has been now trends about CRT. There has been use of CRT beyond kidney support, and extra purpose therapy has been discussed. Now people have started thinking about CRT beyond the kidney support, and the fundamental principle is that it takes out cytokines and endotoxin, so somehow it attenuates the cytokine storm. There are evolving filters which are coming up, and a recent study in 2024, they looked upon the selective cytopheretic device, and they found it feasible, safe, and demonstrated probable benefit for critical incident who requires RRT for AKI. So things are coming up, but there are studies which will be needed. Now the last slide I will be discussing a role of precision medicine. This is the future where people have used different biomarkers. They have done the clinical judgments, and then integration of these sepsis biomarkers and AKI biomarkers like Perseverance model, Persevere-2 model, and these kidney biomarkers like NGAI, PIMP2, and IGF-BP7. And what they have found that precision guided AKI prevention strategies, they lead to targeted future vasoactive support and prioritize early RRT in high-risk phenotype. So a biomarker plus phenotype guided approach leads to more personalized prevention and treatment of sepsis-associated AKI. So the last slide, what is the take-home message? Sepsis-induced AKI incident is multifactorial in origin and associated with adverse outcome. Risk stratification tools for sepsis-induced AKI enables early diagnosis and guide better management. Biomarkers help identify incident at high risk for AKI and predict short and long-term outcomes. Fluids, again, give carefully, reassess often, stop early to prevent overload. And CRRT remains the cornerstone for sepsis-induced AKI, SLED and PTR are the alternatives. Newer filters aim to remove cytokines and neurotoxin, promising the pediatric evidence is limited. I'm sorry I was a little fast, I had to cover so many things in 15 minutes. Thank you so much. Thank you.
Yeah, thank you, Dr. Mridulya, for your nice talk, and it was well updated. And I'm sure that biomarkers have got a revolutionary change in the management of AKIs. But when the renin and prorenin be depended on, I mean, in the absence of those and all. So, what is your point?
It's a renin actually, whenever the patient is suspected of AKI, I think that the studies say that you need to send renin and prorenin level, and once you have this renin and prorenin level, it is supposed to be high. Then they are, categorized into different phenotypes, and it has been seen like drugs like angiotensin 2. They act well on those patients who are having this high renin and prorenin level. So this is the clinical implication of this. Plus, it predicts that this child is going to develop AKI over the next 3 to 5 days. So this is the clinical implication of renin and prorenin.
Any comments from you?
Thank you.
So it was a great presentation. And it was a good learning experience for all of us. Thanks for this.
Thank you so much. Thank you. Thank you so much.
Thank you, sir. I will request Dr. Gopal sir, Dr. Harshvardhan and Dr. Anand sir to please come on the stage to announce the results of the poster, oral poster paper, and which, because we have to leave for the flight, so we have to announce it.
So the first prize in oral presentation competition is Dr. Riya Singh. I request Gopal sir to give. Second in oral presentation is Dr. Aditi Vyas. They are receiving certificate and one extra bag if they have received. So keep the nephro materials in it. Articles. Dr. Aditi Vyas. First in poster presentation, Dr. Anindita Nandi. Second in poster presentation, Dr. Nikita Kumari.
Nikita Kumari.
And the most exciting part was quiz. And the first was Amit Kumar Sarpati, but unfortunately, Amit and Anand Gupta is not getting prize. This is not good. The first, and this is done by Sumantra and Niladri only. So first in quiz presentation, Dr. Utkarsh Srivastava. And second is Dr. Shreya Mehta. हम लोग कैडबरी तो दिला दो they will get an extra American Pulitzer Prize. This is especially selected by Dr. Sumatra.
Very good.
So we will continue with our session.
I will request Dr. Chinmay Beda, please come on the dais.
Next session is by Dr. Chu. He is professor, Department of Pediatrics, KIMS, in Bhubaneswar, Odisha. He is the area of interest with critical care nephrology at HUS. He is president of APNEI 2024-25. He authorized 2 books, chapters, 35 publications in both national and international peer-reviewed index journals. Please.
Thank you, sir, for your kind introduction. Good afternoon. Greetings from the Lord of Patna. So at the outset, I would like to thank the organizing team, Patna team, for inviting me as a faculty. Of course, this is my first visit to Patna. So already I think my previous speakers have everything covered, starting from the incidents to the critical care management, including renal supplement. So I am in the in-between. So my job is in a researchable area where this definite care is not available. So as a pediatrician, what you do? Can you save the life of the patient, or you have to refer all cases to higher center? So the overview, introduction, and etiology in nutrition management. So I start from 2 cases. Case 1, this is a 12-year female child admitted to our ward, fever 5 days, altered sensorium with poor urination 1 day. Outside received 3 antibiotics. Urea was little wholesome, 86, creatinine 2.5. When came to the casualty, patient had blood pressure less than 50 percentile, high grade fever. There was evidence of acute distress, so we shifted to the patient to PHU. In the PHU, patient had evidence of cirrhosis, and we started as per PHU protocol, including fluid bolus, NORAD infusion, and injection marathon, as per renal modification. On day 1, patient serum creatinine rose to 1.8. As per calculated, the baseline creatinine should be around 0.5, so it is more than 3 times the serum creatinine. Also, there is evidence of high urea. There is other evidence of sepsis, so we continue some antibiotic. After detailed evaluation, there was no evidence of any blood culture or urine culture positive. On conservative management, including inotropes and antibiotics, on the day 3, the creatinine gradually reduced and the urea also settled down. On day 6, patient discharged with the diagnosis of AK stage 3. Second case, 3 years male child, fever with Chilean rigor, poor oral intake. This patient has a past history of HIV with epilepsy on AED. On admission the casualty, he has normal blood pressure, normal glucose, but there was evidence of pneumonia in the form of crackles, and APG showing mixed metabolic restoration respiratory alkalosis. Immediately shifted to PICU, put on high frequency, and there was evidence of hypovolemia in the form of IDC was collapsed. So we managed the patient as per PICU protocol. On day 2, gradually increased serum urea and creatinine, and day 3, further increase, but one thing that urine output was maintained. On day 4, due to load more than 10%, as per nephrology consultation, we started 1 session of hemodialysis. And on day 6, he had substance hypertension, oral nicotinamide. Day 10, gradually, on conservative management, urea creatinine comes to normal. On pneumonia panel, there was evidence of adenovirus and case influenza. So this patient discharged on day 12 with a diagnosis of HIV with GT, epilepsy, and pneumonia with stage 3 AKI with result. Okay. So I think we will not cover to the definition already. My previous speaker has already described definition. So straight away I will go to the epidemiology, etiology. Before managing patients in AKI, first you know the etiology and pathophysiology, because your management depends upon the etiology and pathophysiology. Yes. So very simply, the classical teaches pre-renal and renal or entering and post-renal. There is myriads of causes of AKI. So this is the latest study published from, I think, India. There are 10 centers involved in this study. They have seen now one thing regarding etiology. Compared to developed country, developing country, there is shifting of etiology. In developing country, non-renal causes are more common compared to developed country. In the form of dehydration, sepsis, and this nephrotoxic drug exposure. But in unlike in developed country, more common they are surgery, following surgery, also sepsis and nephrotoxin. These are the more common causes of AKI in children. This infection, glomerulonephritis, diarrhea, pneumonia, non-renal are more common compared to renal cause. So these are basic in notes of pathophysiology. So what happens? AKI presentation is silent. Most of the cases there occurs the causes of AKI. There occurs multiple pathophysiological interactions to produce AKI. So it depends upon the susceptibility of a particular host and the intensity of exposure of various insult. This cartoon shows that all so many causes can cause AKI, and the each circle depends upon the magnitude of the AKI. So how will I approach this case of AKI in a patient in a issue? So there must be AKI risk stratification. My previous stratification here detail is described. Renal injury index, including biomarkers and clinical, then cause identification, renal, post-renal, then AKI classification, KDO classification, and staging. Stage 1, 2, 3 conventionally, stage 2, stage 3 was taken to severe AKI. Then you need to go for pre-KRT supportive therapy and fluorescence stress test. Nowadays, so many importance given in the fluorescence stress test. If any child on presentation, if there is evidence of hypovolemia, if you are giving isotonic saline, 10 to 20 ml per kilo over half an hour, good for 2 hours. If within 2 hours child passes around 2 ml per kilo, the fluorescence is responsive. Less chance of going to severe AKI. Next is the appropriate KRT or the organ support therapy. So history, I think all of you know. Examination, investigation, depending upon the initial diagnosis. Peripherals we have covered reticum, LDH, basically more important in case of suspecting HUS. If you are suspecting AGN, post-operative glomerulonephritis, then ASO, C3, C4. If you are thinking autoimmune causes, then you have to go for autoimmune workup. And if you are thinking any post-renal cause, then you have to think for imaging, ultrasound. And there is a different role of biopsy on explained AKI after excluding hypovolemia on explained. So all investigation depend upon your initial diagnosis. Now, urine sediment examination has a role for old teaching. This muddy brown cast suggests severe type ATN. Now, as my previous speaker already described, there are so many urinary indices, but these urinary indices have some fallacy. Here the complication of AKI. So hypertension, hyperkalemia, dyspnea, metabolic acidosis is one of the armamental where conservative management really helps as far as the AKI outcome is concerned. So the goal should be you have to a second thing, if you are having fluid overload, so you think of fluid removal. So fluid is already Murthy described the fluid choice, especially sepsis is concerned. But one thing, there are so many controversies, balanced crystallites versus isotonic crystallites. So latest study last year, still some difference in balanced crystallites as far as the mortality and mixed RRT is concerned, but still sample size limited. So there is no definite recommendation. All types of AKI in children, you should first go for balanced solution or isotonic solution. And balanced solution is not a cost-effective solution. Next, ROSE protocol. If resuscitate, then optimize, then stabilize and evacuation. Now, maintenance will be careful. If a child is only one stage, so you have to use the formula. this 400 ml per meter square plus any output, either stool or any extrarenal loss you have to take account, and fluid removal is very important. Now, fluid removal, if you remove excess fluid, it will also detrimental. So you have to balance under hydration, over hydration. You have to balance. Now something regarding diabetes. So diabetes, except for hypovolemia or your fluorescent stress test, there is no role of diabetes as far as the prevention and AKI management is concerned. Insufficient evidence to support other pharmacotherapy like mannitol, phenylephrine, and NAC in preventing need for KRP. One KDIGO 2012 recommends theophylline has a definite role in preventing AKI in severe expected needed if you start within 1 hour of life. So the use of diabetes must not be a reason to avoid or delay the KRT in indicated cases. It's a very important message. If an essential you go for diabetes, otherwise don't delay to prevent the KRT, you go on giving diabetes. So this picture is, right side picture is very important. So overhydration and underhydration, both are detrimental. So the ifs of thought. So you have to be judicious. Now pharmacotherapy, already I have discussed, complication, hypertension, I think all of you know, symptomatic and asymptomatic. Next, pulmonary edema, oxygenation, furosemide, dopamine, monitor for the central venous line, acidosis. Acidosis, first line management, fluid therapy. Only documented severe acidosis, pH less than 7.15, you can consider sodium. Again, one detrimental effect of sodium, it can cause also hyponatremia and fluid overload. So be cautious. Next, overload, fluid restriction, salt restriction, and hyperkalemia. Obviously, if there is life-threatening hyperkalemia, then calcium treatment should be the first choice. Then, depending upon the level, you can go for nebulization and other glucose insulin infusion. Now, drug modification, as per your eGFR, usually as per the GFR above 50, most of the drugs they do not require modification. And always try to combination of nephrotoxic drugs. Nutrition, there is a guideline given by the clinical practice that pediatric renal nutrition task force. So they have given importance the normal calorie, rather 30% above the basal needs, and also normal protein. And any person having KRT, you have to increase the protein up to 3 grams. This guideline, basing this general care, you have to be drugs disease specific management. If there is functional AKI, you can give isotopic fluids. Tropical fever, if there etul is there, you have to go for the as far as the etul is concerned. Glomerulonephritis, supportive therapy, HUS, supportive plasma exchange, eczema. So everything depends upon the initial. If you are suspecting a post-mortem cause, post-mortem heart, then you should go for catheterization of heart. If you are going for any dialysis, first you catheterize, relieve the heart. Now already, I will skip this slide. Already Dr. Muthu discussed in detail sepsis-induced AKI in children. But one thing, neonates and children merit consideration including sepsis-induced AKI. Those are guidelines there, but it is not graded. Whether this adult guideline will be applicable to children or not. Now there is something regarding contrast AKI. So first thing, still is not uncommon. Though less different compared to adults, still not uncommon. It depends on the multiple risk factors. Any medication, previous underlying chronic liver disease, kidney disease, or any degree of aggression. So, one protocol says if any patient has risk for contrast-induced AKI, always give isotonic crystal 3 ml per kilo per hour 1 hour before, and half of the dose at least 4 to 6 hours after the contrast. No role of N-acetyl cysteine, sodium or vitamin C in furosemide. Though KDIGO 2012 guideline recommends some role of NAC in preventing contrast-induced AKI in adult, but latest recommendation that evidence is very limited. Okay? So, in which case one can predict the failure of conservative management. So, after despite every effort, can we predict this person most likely to needs KRT? So, persistent oliguria. So, in the absence of any metabolic or clinical complication, if persistent oliguria in the persisting beyond 48 to 72 hours, a bedside decision one should go for KRT without delay. Because previous speaker already mentioned, if you delay the KRT, there is mortality high. progressive azotemia, elevated biomarkers, high renal enzyme index. RAI more than 8 can tell severe AKI because, but if renal enzyme index more than 20, less likely to manage by conservative management. And underlying, of course, conditions. Okay, these are indication of KRT. Already, Dr. Rajiv has mentioned what the indication of KRT. So, outcome AKI, here is the long-term outcome. We will not go detail. Now, something ninja protocol. I think all of you might be knowing this Cincinnati Children's Hospital. They have done a good work in ninja. That means nephrotoxin injury negated just in time action. That means electronics records will give a signal to the treating physician that your patient is having serum creatinine high. So you take care of that patient. So by this ninja protocol, 40% reduction of nephrotoxin exposure and 60% reduction of AKI is possible. Avoid hyperglycemia, a routine monitoring of the urine output and serum creatinine in children, a risk of developing AKI. Now, what is new in the AKI management? I think my next speaker, Dr. Amit, will tell in detail what is new in the AKI management, including AI and precision-based management. So, I am just skipping this slide. So, follow this is very important. Already we have discussed in previous session. As per KDIGO recommendation, all patients API, even normal respiratory discharge, must follow at 3 months, and any patient AKD beyond 3 months you have to follow 3 to 6 months, including blood pressure, hypertension, hemoglobin protein estimation, because it has been seen 10% child can have CKD as early as 1 year. Okay, in a 10-year follow-up study, children after renal failure, 16 of the initial 24 survivors they analyzed at 10 years. 25% survivor in acute episode, they show renal anomaly, and one died at 8 years, ESRT. That's why this is the importance of monitoring of AKI, all cases of AKI, even normal renal function and discharge. So message is, AKI is common in hospital in children. Serum creatinine along with various biomarkers and imaging with the help of artificial intelligence can help in prevention, early identification and personalized care for AKI. No role of dopamine and furosemide in prevention or treatment. Normal calorie and nutrition. Thinking in view of if you give high protein, the urea may rise. But KDIGO concerns, the latest clinical guidelines says, if any patient having KRT, especially CRRT, they lose more amount of protein in the form of amino acids. So all nutrition as per RDI should be, rather protein should be given up to 2.5 or 3. Balanced solution has some benefit. As far as the motor is concerned, there is no recommendation from an official guideline. Balanced crystalline solution should prefer compared to normal saline, especially research for area. Not everything is acute in AKI. It has some long-term adverse effect, like in the form of proteinuria, persistent hypertension, including CKD. Thank you.
Thank you, Dr. Bera, for a nice talk, elaborate enough for everybody to understand. But I'm sure that few of the things which you told is age-old, that is furosemide, stress test, and these things we used to do even 50 years ago.
No, sir. They used to know whether this is renal or intrinsic. Nowadays, furosemide stress test stratification. If any child patient not responding to furosemide, after correction of volume status, more likely to develop severe AKI compared to those responsive to furosemide in the form of 2 ml per kilo.
Yeah, we used to do that in clinical.
See, now it can help in this stratification. That's what in my own.
I think the key word is, of course, the fluid stewardship. That is very important what you were before. So that's very important. Thank you very much for your nice talk. Thank you very much.
Thank you.
We will close the session right now because the lack of time we are running short.
Yes, last speaker, Dr. Amit.
So thank you, and I will request Dr. Harshvardhan and Sir to please honor the chairperson and the speaker. Thank you all the listeners. We are showing the patients learning after 5 also. So the last but not the least, for the session, I will ask Dr. Abhishek Raman and chairperson, Dr. Anand Gupta and Dr. Harshvardhan. And for the large speaker, Dr. Amit Kumar Chattopadhyay, please. Dr. Anand Gupta will join soon.
I would like to welcome Dr. APNEICON Saraswati, Additional Professor AIMS Bhubaneswar, with areas of interest in nephrotic syndrome and
So, I will introduce my dear friend Dr. APNEICON Saraswati. He is a very hard-working pediatric nephrologist working at AIMS Bhubaneswar, and he has more than 100 publications in national and international journal, and I invite him for the last lecture of this APNEICON 2025.
Thank you, Dr. Anand, for your kind words. This is the last talk, right? This is on AKI in children and anything new. So, if you are especially listening to Dr. Rajesh Sinha, sir has told that there is nothing significant which is clinical importance has been done for last 15 to 20 years in AKI. Whatever has been done, it is mostly for diagnostic purpose and some modification in the treatment, right? So, based on that, I will try to tell you what are the diagnostic changes happened over last 15 years, 10 years or 5 years. On the basis we will try to learn what is the difference in AKI, AKD, what is the clinical AKI, what is the endotyping in AKI, and role of artificial intelligence, which is this is the era of artificial intelligence, right? So many of these things already has been told to you. Probably it is a repetition because as I already mentioned, there is nothing new has occurred since last 10 years, right? So as you know, AKI basically it is sudden impairment of the kidney function occurring over a period of hours to days, right? It is limited to hours to almost 7 days, whatever you thinking, right? And it has several etiologies, and the clinical manifestation could be simply mild increase of creatinine to completely anuria, and many a times it is tubular damage which lead to this AKI. Coming to the incidence of prevalence, it is almost 26% in the children, and for any stage, as the stage advances, the moderate to severe is almost 14%, and the risk of mortality increases as the severity increases. So how will you define AKI? Though AKI definition has journey of 30 years, almost 100 years with 30 definitions. The latest one which we are following is KDIGO definition, which is based on your serum creatinine and urine output. So these are the two functional markers, right? And the major problem is with the definition is use of serum creatinine and the stipulated time of 7 days. Because so what happens beyond 7 days we don't know, because we make a diagnosis of CKD after almost of 3 months. So what is happening in 7 days to 3 months of duration? There is always controversy. So that led to a new terminology that is called as acute kidney disease. So anything happening within 7 days of past 7 days, it is basically terminology AKI, as you were that were diagnosed with the help of your KDIGO 2012. So beyond that, 2 to 3 months usually termed as AKD. Always remember that this AKI is a part of the AKD. Right, and those who are progressing, they can end up in CKD. So what happened is with any injury, any child, sick child who is admitted with some injury, there has some inflammation, endothelial injury which causes tissue damage, which results in the acute kidney disease. And once the creatinine rises, we picked up them, and based on the degree of rise in creatinine and decrease in the urine output, level them the AKI. So basically AKI is a subset of AKD. And many of these AKI, as well as undiagnosed AKI, which is a subset of AKD, later on, if not improving, they further progress to CKD. So that is why it is important to understand AKD nowadays. This is what the operational definition says. This is the AKD spectrum, whereas the AKI is on the part, which is basically the 7 days, which is a functional criteria based on urea creatinine and urine output. There is no structural criteria for this. It is only functional basis. Whereas AKI of less than disease of less than 3 months, we categorize them AKD, which is basically including the AKI along with if your GFR is less than 60 ml, or the GFR reduced by 35% from the baseline, or increase of the creatinine by 50%. And the structural marker is proteinuria, or there is a hematuria is there, right? And if it is beyond 3 months, that is termed as CKD. Now, what are the major challenges with that? One part of the challenge is duration. The other part of the diagnosis for the definition is creatinine, right? Because the creatinine is its own problem. The creatinine rises very late in AKI, right? By the time you are diagnosed, almost 50% of the nephrons is gone. And it is also, you know, from the biochemistry test that it is the creatinine levels are changed by so many other things like volume distribution, diuretics use, other altered creatinine production like muscle mass, right? So this is the typical. This cartoon will tell us what actually happens, right? If you see the normal GFR and the creatinine is the blue one and the GFR on the curved graph, right? So you can see that until the GFR is decreased by your 50, almost 60, your creatinine is almost same, right? So you are not able to pick. So now major this has been gone to how to pick before the creatinine has increased. The decline in GFR, whether there is some markers, functional or any marker, which can detect the AKI within that period. There is no increase in the creatinine or decrease in output, but your damage factors like the biomarkers are there. So now that is called as subclinical AKI, which has been classified as 1S. Suppose if there is no damage marker but only functional loss, that is prerenal edema 1A, or the damage marker positive, loss of function is classical 1B. So now the focus is that identifying the subclinical AKI, because if you intervene that, you can prevent the progression to frank AKI, right? So that is the importance of using the biomarkers. Now, this is about the diagnostic. Second one is stratification. Already this has been discussed. There are two stratification things we are using. One is renal angina index. The other one is FST. Renal angina index, which is basically the risk strata into injury. Already discussed. Any score of more than 8, it predicts that the child will go into AKI stage 2 severity in 72 hours, which is a very good sensitivity specificity, which is around 85.85 and specificity of 0.79, right? Similarly, for furosemide test, you should do a furosemide test where you give IV furosemide 1 gram per kg to naive or 1.2, which already received LSH. Then you monitor the urine output after 2 hours. If it is more than 1 ml per kg, there is a low risk of AK. If there is less than 1 ml per kg, high risk of AK, need of RRT. Now, what is new on that? This has been there in practice for last 10-15 years, right? What is new is combining this risk factor and biomarkers. What Dr. Rajesh Sinha and Sumant were telling, the Cincinnati study, which has used this biomarkers plus risk stratification factors. So what they have done is, any child admitted to PICU, they have used first, in the past 12 hours, they have used the renal angina index, right, to classify whether it is severe one or a normal. So if it is more than 8, then they use the biomarker like urine anger. If it is more than 500, then high chance that the child will going to require your renal replacement therapy. The moment the fluid overload crosses more than 10, you start RRT immediately. Whereas if it is both are negative, your RI index is less than 8 and NGAL is negative, less likely that this child will require RRT. So RIA more than 8 is a positive predictive value of 0.7. When you combine RIA plus NGAL, the combination positive predictive value is almost 6%. Whereas if RIA is less than 8, NGAL is negative, is a very high negative predictive. High negative predictive value, you are easily rule out that this child will not going to do AKI, which is almost 98%. So that is the utility. This is the newer thing. Use of stratification plus biomarker to decide your renal respiration therapy. Now, the next newer thing is AKI endotyping. Already Dr. Mutrija has touched upon that. So what is endotyping is? So phenotyping is what we observe in a child, right? The second decade. So studies have shown that all-cause mortality in the treatment group is reduced to 14% as compared to the placebo, which is 26%, which is significant. So the neurotherapy not in childhood, children with AK, but adults. Probably later in a few days we'll come to know. Now something about the artificial intelligence in the AK. As artificial intelligence has gone to every field, similarly it has come to the kidney disease. AK has a very good thing. What we will do is, so they analyze the big data from the hospital. So it will include the risk stratification, what are the risk factors, requirement of RRT, then it prepare an algorithm. And when the next patient comes, it will analyze and tell how the patient will be behaving. So it includes also biochemical markers, chemical parameters, as well as the patient biopsy finding, and so many clinical taking into clinical parameter, other things. It will give a flow algorithm that will lead to that will help in making clinical decisions. This is the predictive models what we have seen. So acute kidney injury, so you can risk assessment, standard risk, routine care. If a high risk, you can go for clinical focus care. So last thing is long-term monitoring. As Dr. Rajiv was telling, most of the AKIs, we discharge them with a normal creatinine. What happens after 3 years, 2 years, they are coming with CKD, we are not monitoring. This is one of the this protocol has come the last 3 months back from same Dr. Saina Menon group. So what they have done is, so what they have advised is, so even the child, somebody is having AKI without risk factor, stage 1 AKI, recovered completely, follow with BP at least 3 to 6 monthly with the general practice there. But if somebody has a risk factor, moderate to severe AKI, that is, so it is must to monitor with the creatine as well as monitor scans. Scans is, you have to do a kidney function urea creatinine test. If you have a cystatin, it is well and good, but at least do a urea create. Along with, you advise them for not taking unnecessary medication, you monitor the blood pressure. So generally, this has to be done with the nephrologist, right? So remember, for any child who has recovered AKI or a risk factor, even if they are normal creatinine discharge, ask them to follow up every 3 to 6 monthly till 1 year, then they can follow depending on the clinical course. So the take-home message is utility of biomarker and risk stratification is key to the early identification and management of AKI. Endotyping is help in prognostic and predictive enrichment. Big data and machine learning is future, and long term, don't forget to monitor them in long term. That is the key message. Thank you for patient.
What would be the normal value of pediatric
I don't remember exactly the values because they are not totally as of now using it, right? Because there's on problems because we are most of the centers there is only research purpose we are using. Diagnostic clinical purpose we are not using it.
Thank you so much, sir.
Can I ask one question last year, please? So I think you are good researchers. I just don't want to lose the opportunity to know what is the prospect of AI, because as you discussed in last few slides, AI, what is the prospect of AI as a researcher? What are the domains that we should explore in terms of projects in coming years as far as the role of AI is concerned in predicting or managing AKI? And what are the research prospects as far as AI?
Research prospect is maintain the data. The patient admitted ICU, have a data. You maintain all your ICU like the scoring system what you are using routinely. Along with that, if you have facility of biomarkers and you can do all this risk stratification methods and integrate those with your
PSU 6 scoring like prisons score 3, all these things, right? Key sofa score, all these things. Then you try to bring out a model to predict them which child will, and we monitor the fluid, daily fluid overload, all these things. Then to try to make a algorithm to predict which of the children will end up in AKI or requiring RRT. That is the best thing. Thank you, Dr. Amit, and I will request Gopal sir and all to please honor the chairpersons and all the people. So this is, we come to the end of this beautiful scientific session. From the last 24 hours almost, I am with you except the night, and I tried my best. I have done justice to my whatever things I am doing. तो इसके बावजूद भी अगर कोई मेरे जीवा से मिस्टेक हुआ हो या फिर गलती हुई तो मैं क्षमा चाहता हूँ इस पोडियम से माध्यम से किसी को मैंने किसी बात से जरूर पहुँचा.
Before we end this program, one man who did everything is Dr. Chandan, and we must give him a big hand, because without him he has been the master of ceremony and his job has been the most difficult one. And I would really thank you, Chandan. And please, sir, I would like Dr. Gopal Prasad sir to felicitate him for his tremendous job. And special appreciation for Chandrasekhar,
जब मुझे बोला है कि मुझे करना है, एक आदमी जो पूरा सपोर्ट निभाया एक्सेप्ट गोपाल सर एंड हर्षवर्धन सर, चंद्रशेखर, he must come on the stage.
उसके लिए भी जोरदार तालियां चंद्रशेखर की.
It's like that whole of the conference. रीढ़ की हड्डी की तरह कॉन्फ्रेंस को संभाले रहे. खाना पीना, आना जाना, सॉल, momento, everything. There's a big round of applause for Chandrasekhar. We need such kind of. He managed everything, scientific session, everything in there. And I will take liberty for 2 more minutes. Big round of applause for 2 people, that Dr. Harshvardhan and Dr. Gopal sir, for organizing APNEICON in the Patna. And this is the best conference among many conferences. Very good scientific and the must have both of you. So please come on, please come on. And Dr. Anand Gupta also can join. Anand Gupta, any other? सब लोग जितने लोग ऑर्गेनाइजिंग कमेटी, प्लीज सर, 1 फोटोग्राफ. सर 6 बजे क्या 2 मिनट में और क्या होता है?
ये आओ, ऐसी बात.
सब लोग सारा सामान all the faculty, ma'am from Guwahati, Shillong, this is really starting पूरी भारत यहाँ पे है.
बोलोगे सब नहीं यार, तुरंत करेंगे हम. रुक जाओ सब कुछ सामने आओ. गोला बनाइए. नीचे आ जाओ ना, नीचे आ जाओ, कोई दिक्कत नहीं. नीचे आ जाएगा, नीचे आ जाओ.
हेमंत सर प्रोफेसर पीडियाट्रिक्स हैं, सुबह से अभी तक बैठे हुए हैं. सारे डेलीगेट जितने लोग हैं सब लोग प्लीज ऑल ऑफ यू कम. अरे आ जाओ जल्दी है, बहुत सब लोग आइए.
कितने बढ़िया आइडिया दिया है।
आ जाओ सब लोग, आओ आ जाओ।
कॉन्फ्रेंस खत्म होने वाला है।
सर आप लोग पीछे वाले आगे आ रहे हैं, आगे आ रहे हैं। डॉक्टर साहब थोड़ा आगे।
हमारा है
इस तरफ आ जाइए, यहाँ सामने आइए ना।
बना लेना तो यहाँ चल लेते हैं। मैं जाऊँ
जो भी आपने दिया है वहाँ पे कंसोल पे वहाँ से ले लें। And there's also a scan system, they can scan for your photographs.
इसको स्कैन कर सकता है।
हाँ, AI use a scan system.
आ जाओ राजना। आप ऊपर आओ, सब लोग है ना, सब हो गया। जैसी आ जाओ, यहाँ दोनों भी नहीं है।
ओके, और फैलिए थोड़ा सा।
हो गया, ठीक है।
अरे आप नहीं सही है, प्रेम को बनिए नहीं यार, बढ़िया से सही क्या जिंदगी भर घूमता रहेगा, फोटोग्राफी क्या करना है। चलो
ठीक है, देखिए यहाँ
अब ये डॉट
निकल ही जाऊँ 8 बजे
देने के लिए वो आया था।